Hello, good afternoon, everybody. On behalf of Shri Shankara Cancer Foundation and Shri Shankara Cancer Hospital and Research Center, we welcome you to this webinar. I am extremely sorry for the delay in webinar due to some technical audio issues. So now we will begin. Since the COVID-19 pandemic has started, we have listened to and participated in several webinars in breast cancer and learned about a lot of new developments. The focus in this webinar is to see how we can incorporate these new developments into our clinical practice. With this in mind, we will, without much ado, we will proceed with the seminar. I request Dr. Govindrajan, Head Onco-Imaging at Apollo Hospitals, to begin his presentation on imaging concepts in breast cancer.
Yeah, good afternoon.
Dr. Govindrajan, you can start sharing your slide.
Good afternoon, Dr. Ravi. Thanks a lot for this opportunity. The topic given to me is imaging consensus in breast cancer. Ironically, as in many other fields of medicine, the consensus is not extremely encouraging, particularly for the use of advanced imaging technologies. Okay. So when we talk about imaging in breast cancer, we start with the screening. Hello, am I audible?
Yes, sir, you're audible.
Okay, I was getting some noise background, that's why. Okay, shall I continue?
Yes, sir, please.
Yeah. When we talk about imaging in breast cancer, it starts from screening. And once the suspicion is confirmed on biopsy, we talk about further imaging for evaluation of metastatic workup as well as treatment response evaluation, and later on follow. When we come to the screening itself, there is not much of consensus whether to do screening or not to screen, even though majority of the world, across the world, it is believed that early detection of breast cancer actually brings down breast cancer mortality. However, there are obviously difference of opinions, particularly the one paper in New England Journal of Medicine, and of course the commentary by our own Dr. Badwe, where they commented that increased detection has caused more harm, particularly with respect to detection of 25% of overdiagnosis of breast cancers, which otherwise wouldn't have caused any problem for the patient. So that apart, there are again many societies or many agencies recommending different kinds of screening protocols, though most commonly quoted among the imaging community is American College of Radiology, so which gives guidelines for average risk as well as higher risk group of people, whereas average risk starts with 40 to 49 and 50 74 years. Beyond 75 years of age, of course the life expectancy of the particular person decides whether we have to go for screening annual mammography or not. Whenever there is a dense breast, always use ultrasound. High risk group, the screening is preponed by a few more years, by generally a decade. NCCN guidelines again suggest that or recommends that you have to start screening at the age of 40, and also it adds that consider tomosynthesis whenever it is available. So NCCN guidelines also says that there is improved detection of breast cancer by DBT, though it's not very sure whether there is improvement in disease-specific mortality. This special note is given in NCCN as well as ACR guidelines for African American women for screening, where it's relatively more aggressive tumors as well as early occurrence of tumors. Even though the Asian and Indian women fall into the same category, there's hardly any specific guideline in such way. Tools, what all tools do we have for screening of breast cancer? Mammography, digital mammography is preferred, with or without digital breast tomosynthesis, which is a 3D counterpart of 2D imaging. Ultrasound, and whenever there is elastography available, please use that, because that helps us in identifying or characterizing the lesions better. And whenever MR is used as a screening tool, always use with contrast dynamics. Other tools like CT, PET-CT are not indicated for screening. Again, ACS recommends breast MRI screening as an adjunct to mammography only in cases of BRCA mutation or whenever there is a lifetime risk of more than 20-25%. And in others, it is not very much well accepted. Mammography has got limitations, particularly when you have a very high or heterogeneous density, whereas it is extremely good when the breast density is predominantly fat, as in this case. So if you have a heterogeneous density breast on mammography, you might have to utilize other modalities like ultrasound, elastography, and MRI. As in this case, this is a normal looking breast mammography, whereas this is a typical speculated tumor in a predominantly fatty breast. Another patient with microcalcification scattered across, typical of cancer. Ultrasound showing a benign-looking tumor here, whereas this is another patient where a speculated lobulated large hypoechoic mass, which is typical of cancer. Elastography, as I said, helps in identifying or characterizing the lesion to be either hard or soft. So whenever there is hard, we always feel that it is cancerous. MRI is probably the best as far as spatial resolution is concerned. Outlining of the tumor is the best with MRI, particularly with MR, dynamic contrast dynamics. When we talk about contrast dynamics, we have three types of curves or signal intensity curves. That is, the contrast enhancement is plotted against the time. So early peak of enhancement and continuous enhancement, increase in enhancement, which is type 1, typically seen in benign conditions, whereas early peak of enhancement followed by wash off, quick wash off, is predominantly seen in cancerous patients, whereas type 2 curve, where the plateau occurs after the early peak of enhancement, is generally an indeterminate category. A typical screening mammography report shows all these parameters, shows the breast density and also the BI-RADS category, then the recommendations, and also it tells about what exactly the BI-RADS mean. BI-RADS 4, what is BI-RADS 4A? That is more than 2% of incidence of cancer in those kind of cases, like that. So this is the typical example of a screening mammography report. A note on BI-RADS, which is a standardized lexicon which is used across the globe to make it more reproducible and also more uniform across the platforms. The BI-RADS platform has become so famous or so popular that many other organs are also utilizing the same kind of lexicons, as in this case of head injury where HIRADS is used, PI-RADS in prostate cancer evaluation, LIRADS in lung cancer screening, etc. So workup of patient is starts once you detect some suspicious lesion mammography or screening tools, or if the patient comes with a breast lump or any other symptoms related to breast cancer. Once the diagnosis is performed, metastatic workup, depending upon the type of tumor, and of course, rarely we come across breast cancer presenting as metastasis, then we chase the primary. So typically, triple assessment is performed. After the clinical evaluation, imaging involves predominantly ultrasound and mammography and pathological diagnosis. When we talk about imaging, this is an example of a patient showing a breast lump in the upper outer quadrant on mammography, typical microcalcifications within the tumor, speculated tumor, architectural distortion. Ultrasound shows a typical hypoechoic irregular shaped mass with distal shadowing. So this suggests it's a cancerous patient. Biopsy of the breast lump, preferable thing is to perform a core biopsy because it is relatively easy, safe, as well as it provides sufficient tissue for IHC and biomarker evaluation, particularly with respect to the hormone receptor status and Ki67 status as well. So ultrasound is a preferred method for imaging guidance because it is relatively easy, as in this case, you can identify both the needle as well as the tumor. The axillary node assessment is a very important step in breast cancer evaluation. There are some specific parameters of high resolution axillary ultrasound imaging findings for lymph nodes when to suspect metastasis in them, like cortical thickening, either focal or diffuse, hilar effacement, hilar fat is effaced, or non-hilar kind of a cortical vascularity, which happens because of metastatic deposit in the cortices, etc. Again, whenever there is a suspicion of lymph node being involved by cancer, core biopsy or ultrasound guidance is recommended. This is a typical example of an axillary lymph node which is infiltrated by cancer. What is the purpose of imaging after confirmation of breast cancer? After confirmation of breast cancer, we need to do imaging for mapping of the disease to identify the exact true size of the lesion, to enable and facilitate all aspects of locoregional management, monitoring response to neoadjuvant chemotherapy, as well as in guiding management of the axillary lymph nodes. Again, there is another parameter involved, which is the prognostic staging, which incorporates the biomarkers into the morphological staging. And this many times causes stage migration, whereas triple negative breast cancers generally go for upstaging. HER2 new expression tumors generally go for downstaging. So this is the typical TNM classification of breast cancer. Early breast cancer till T1, N1, M0, whereas T2 and beyond is LABC. There is overlap at T2, N1 level, even though many practitioners consider this to be an early breast cancer. Again, NCCN guidelines are very, very conservative as far as imaging workup is concerned. There is hardly any role for metastatic workup in early breast cancer, particularly when the patient is clinically asymptomatic for metastasis. Even though LABC, there is some scope for further investigations. And PET-CT as such is generally not considered a mandatory thing for metastatic workup in clinically non-metastatic or unsuspected non-metastatic breast cancer patients. However, a minority of patients actually present with metastasis. And hence, this awareness is increasing among both practitioners as well as the patients, which is causing increased tendency to utilize PET-CT for these kind of metastatic workup. We in our center, we did a retrospective analysis of about 168 patients. This abstract has been accepted for presentation at RSNA 2020, where we identified that nearly 1/3 of patients are upstaged, either from EBC to LABC or LABC to metastasis. And we concluded that FAT and FDG PET-CT scan seems to be an appropriate initial investigation in patients with clinically stage early breast cancer, though prospective studies are required to categorically state this. Example of an early breast cancer on PET-CT, clinically early breast cancer, only one single node is positive. PET-CT shows an internal mammary lymph node. The patient was converted to LABC and neoadjuvant chemotherapy is given. Post-chemotherapy, we can identify tumor is resolved, lymph node is resolved in the internal mammary region, and significant regression of the axillary node. Another patient, early breast cancer, lower inner quadrant, no axillary lymph node, internal mammary lymph node present, converted to LABC, and again the patient goes for neoadjuvant chemotherapy. LABC patient, clinically LABC, because the skin is involved here, but PET-CT shows multiple liver lesions, even though clinically patient was not having any symptoms related to metastasis. Very early breast cancer, otherwise clinically would have called it early breast cancer, non-metastatic. PET-CT was performed and it shows activity in the liver areas without any CT scan abnormality. MRI was performed for these cases. Multiple lesions were seen. Biopsy was performed and it was confirmed to be metastasis from left breast cancer. So once you rule out metastasis, what is the role of imaging prior to surgery? Imaging is helpful to improve delineation of the true size and true extent of the tumor, that is the index tumor, help the surgeon appropriately define the resection margins, and detect additional either ipsilateral or contralateral breast cancers. Again, imaging tools we have, digital mammography and with or without tomosynthesis generally helps in identifying multicentricity as well as distribution, particularly when microcalcifications are the way of diagnosis. High resolution ultrasound, both for the primary tumor as well as for lymph nodes in the axilla. Ultrasound also helps in localization of the tumor margins before NACT. Breast MRI, whenever it is available, it's preferable to use this because it has got higher contrast resolution and predictably identify more number of ipsilateral as well as contralateral breast cancers. Although this particular trial has paradoxically suggested or found out that there is increased incidence of resurgeries even though the tumor is identified before surgery on MRI. That is probably because the MRI is performed on a prone position, whereas surgery is performed on a supine position. And when the trial was performed between 2004 and 8 in UK, including around 1,600 patients, there was no option for performing breast tumor localization when the tumor was seen only on MRI. And the broad consensus, of course, regarding PET-CT is that it is of no use for assessing the primary breast cancer. However, whenever you do PEM, positron emission mammography, that can be as good as mammography or as good as MRI for identifying multicentricity. This is an example where whole body PET-CT scan is dismal in its performance for identifying such a huge tumor, which is so well seen on mammography. A patient diagnosed with breast lump, MRI, mammography showing huge area of density around 4.5 to 5 centimeter density. Then the PET-CT scan was performed in thinking that there might be metastasis. No axillary nodes, no internal memory nodes, no metastasis anywhere else. So this is a false negative study for PET-CT scan. If you don't know the diagnosis, you call it a negative PET. Mammography, very good in identifying microcalcification extent, as in this case, architectural distortion, as in this case. MRI, even better for identifying focal lesions with wonderful delineation of the margins. Of course, MRI is again extremely useful for identifying multicentricity. And in the setting of neoadjuvant chemotherapy, MRI has got a very good accuracy for identifying a tumor response, as in this case, a true negative or a true positive. For example, there is a residual tumor post neoadjuvant chemotherapy, pre-therapy, post-therapy. This pre-therapy, during therapy, and post-therapy. This is the residual tumor. It's a true positive case, which is confirmed to be residual tumor post-surgery. We also have false negatives, as in this case, and false positives, as in this case. Similarly, PET-CT scan is also quite useful for identifying tumor response, as in this case, a tumor neoadjuvant chemotherapy, pre-neoadjuvant chemotherapy, whereas post-therapy, there is significant reduction in the tumor. Accuracy of final predicted response after neoadjuvant chemotherapy among imaging tools is ultrasound is 65%, mammography is 68%, whereas MRI is the highest, but PET-CT scan also comes very, very close. And also PET-CT scan also has the capability of identifying distant metastasis. So to summarize, the imaging protocol for clinically non-metastatic breast cancers is that once you rule out multicentricity and clinically node negative, and if it's an operable breast cancer, use ultrasound axilla with high resolution probe, do sentinel node biopsy if axillary node evaluation on ultrasound is negative. However, if axillary node is positive on ultrasound, then do a guided biopsy. If the guided biopsy is negative, again go for sentinel node biopsy during surgery. Whereas if it is positive on ultrasound guided biopsy of the axillary node, go for axillary dissection. This is the standard protocol which is commonly practiced across globe. But where do we stand with respect to PET-CT scan? Of course, as I shown you in one of our own studies, and also there are multiple studies, many prospective as well as retrospective studies, where the volume of evidence is significantly increasing day by day. And I am not, I'm very, very sure that in the near future, we'll be coming out with a protocol, protocols which make PET-CT as probably one of the initial imaging tools. Whereas in LABC setting, staging PET-CT is of course commonly accepted these days. Bone scan separately is not required when bone metastases are present on PET-CT scan, even though some people perform F18 bone scan or MDP bone scan if staging PET-CT is negative for metastasis. Mammography, ultrasound without MRI to assess multicentricity and contralateral breast cancers. Neoadjuvant setting, pre, during, as well as post neoadjuvant therapy, MRI, as well as PET-CT. Generally, in the Indian setup, more commonly accepted is PET-CT. And follow-up, again, there is hardly any consensus regarding the follow-up imaging, even though many believe or accept or agree that mammogram 6 to 12 months after completion of treatment can be performed, and maybe later on maybe annual mammography screening. Clinical and physical examination, say 3 to 6 months interval. No recommendation for regular imaging follow-up in asymptomatic patients. And in metastatic setup, when we are dealing with palliative kind of treatment, the imaging follow-up is guided by patient's symptomatology. So to conclude, we have too many guidelines which are very, very conservative. And sometimes there is a gray line between what is accepted and what is overkill. We also understand that we have to understand that guidelines are derived from our own practice, and the updates on guidelines are actually guided by the common practice. So in fact, the guidelines are changed because of deviation from the common practice. So we have got innumerable latest technologies available, the diagnostic imaging methods and tools that can improve treatment diagnostic decisions. The results are basically dependent upon not just about the diagnostic accuracy of the imaging tools, but also about the expertise of the multidisciplinary personnel. Breast radiologists and surgeons, as well as medical and radiation oncologists, have the opportunity to embrace this contemporary imaging into the futuristic kind of imaging practice. Number of ongoing and future trials, along with existing evidence, make use of appropriate use of precision imaging tools into the clinical realm and help in better patient management. Thank you very much for your kind attention.
Hello. Yeah. Thank you, Dr. Govindrajan. That
Yes,
was
sir.
very insightful. Come Monday morning, it is likely to help our oncologists in use these guidelines that you have set to treat and follow up the patients in breast cancer.
Thank you very much.
We will take the questions at the end of the webinar, and hence I request all participants who have a question to put the questions in the chat box. And I request all the speakers and panelists to stay till the end of the webinar so that we can answer the questions and clear the doubts and have an interactive session. Now to go on further, I request Dr. Chaya Prasad, consultant pathologist at Sri Shankara Cancer Hospital and Research Center, to share her screen and start talking on her topic, beyond receptor status in breast cancer.
Hello, everyone.
Hello, ma'am.
Yeah, unmute yourself and start.
Okay.
Ma'am, just full screen it.
All right. Yeah, am I audible now?
Yes, ma'am.
Yeah, thank you.
You're muted, ma'am.
Hello?
Yeah.
Okay, I'll start. So my topic for the day is beyond receptor status in breast cancer. To start with, morphology is a gold standard till date, and it depends on grade, type, staging, according to recent WHO classification. And even now, routinely, we practice ER, PR, and HER2 as a prognostic and predictive factors. So what I want to discuss today mainly is the triple negative breast cancers. When I was going through the triple negative breast cancers, this is a thought which came to my mind. I want to be defined by what I am and not by what I'm not. So to talk about the mutational burden in cancer, we see here that the highest mutational burden is seen in lung cancers and melanomas. And where does the breast cancer stand? It stands somewhere in the middle here. And you see on the top is triple negative breast cancers. So coming to the genomic profiling of cancer, breast cancer is not just one disease. This came up 15 years back in Nature. It is the first molecular classification came up like this, which was stratified into 5 different groups. It was luminal A, luminal B, HER2, basal-like, and normal breast-like. So now, why refine the classification? It's for prognostication, risk stratification, and for targeted therapy. So triple negative breast cancers is defined by what it lacks. According to ASCO-CAP definition, they're ER, PR, and HER2 negative, and they're positive for P63, 53, and basal keratins. They account for 15 to 20% in the Western population and 20 to 30% in the South Asian population. Higher incidence is seen in young and African American women, frequently associated with BRCA germline mutations. 75 to 80% are basal-like. They have worse prognosis, and relapse occur within 1 to 3 years of diagnosis with visceral metastasis. It's said that they have a triple negative paradox. That means despite their high chemosensitivity, the median survival with metastatic disease rarely exceeds 12 months. This is just to know the morphology of triple negative breast cancer. So triple negative breast cancer is not just comprised of high-grade tumors. It also includes the low-grade tumors, which are secretory and adenoid cystic carcinoma. Even in morphology, there is heterogeneity. So TNBC, we're going to talk on the heterogeneity within the basal-like tumors. Here you can see it was Lehman et al. Who classified them into 6 groups based on the genetic analysis of 2,188 genes, which was segregated from 21 breast cancer data sets. And it's stratified like this into 6 subgroups, which is based on like 1, 2, immunomodulatory, mesenchymal stem-like, and luminal AR type. What I want to emphasize here is we all know that triple negative and basal-like are not the same. Triple negative cannot be used as a synonym for basal-like. Even though there is a concordance of 70 to 80%, there's always a discordance of 20 to 30%. So now, when I talk about heterogeneity, can we now redefine these subgroups by what they are, so that triple negative, we are going to make it as positive tumors and treat them. So when genetic analysis was done, it's seen that there are varied mutations, and I'm going to first talk on the immunotherapy. The promise of immunotherapy is a paradigm shift in the treatment of cancer. It uses patient's own immune system to target cancer. It has long duration responses in spite of its low toxicity with some limitations. It is a smart strategy to overcome the molecular complexity of cancer. This is just to show the players in the immune mechanism, or what we have. This is the tumor, and that's the stromal microenvironment. There should be a proper balance between tumorigenic and anti-tumorigenic mechanisms. The cells involved in the cells which are anti-tumorigenic include helper T1 cells, CD8 positive T cells, and some plasma cells. And anti-tumorigenic, the pro-tumorigenic cells are regulatory T cells and some tertiary lymphoid structure associated cells. So there should be a proper balance between pro-tumorigenic and anti-tumorigenic elements. So what is cancer immunotherapy? Can we actually activate the immune system to seek and destroy cancer? There are 3, you can do it via 3 means. That one, with checkpoint inhibitors, or via cancer vaccines, or CAR T cells. First mechanism is releasing the brakes. How checkpoint inhibitors work, to start with, this is the adaptive immune response, wherein this is an antigen presenting cell presenting the antigen to a T lymphocyte. So what happens initially, you have CTLA4 expressed on the T cell, which has more affinity for B7, and thereby it inactivates the T cell. So an antibody to CTLA4 would cause T cell activation. The second thing is the effector phase, which is seen in the peripheral tissues, wherein there is expression of PD-1 by the T cells, and in turn, this PD-1 causes elaboration of interferon gamma, and that interferon gamma causes activation of PD-L1 on the tumor cells as well as in the microenvironment. So normally there is a handshake with PD-1 and PD-L1, thereby preventing autoimmunity to all kinds of viruses. So when we give antibody and block this handshake, and that's when activates the T cells. So this is just a pictorial illustration of adaptive and constitutive responses. And here you can see this is the IHC of PD-L1, which stains the margin, basically the immune cells. And this is called the adaptive immune response, wherein almost all the tumor cells are staining diffusely and expressing de novo PD-L1. So this is in turn made as immunoscore. The immunoscore is something called a standardized quantification of the same, what I spoke just now, into a prognostic index. Thereby, this information is better than any of the TNM staging system we have now. So the future TNM would look like this. Along with TNM, we would have tumor infiltrating lymphocytes and tertiary lymphoid structures. This breakthrough came in 2018. Nobel Prize winners in medicine, Professor Honjo and Allison, who contributed to PD-1 and CTLA-4. This is just to say now PD-L1 IHC, we have diagnostic comparison and complementary diagnostic test. The aim of this is to separate the potential responders from non-responders for a known therapeutic agent. That is, the test should be able to predict which patients will respond to a given drug. Now, at present, pembrolizumab and atezolizumab is approved for breast TNBCs. The second thing is the BRCA1 mutation. We know they're tumor suppressor genes, and they work through homologous recombination pathway. 15 to 20% of women possess germline BRCA1 and 2 mutations. The biological effects are different with respect to post-NACT. It's said that the germline BRCA1 mutations are better. They have 63% of pathological complete response rate when compared to somatic inactivation. So thereby, that forms an important marker of response to platinum agents. There's another thing, Media Genetics, who came up with this new score, HR deficiency score. They say that higher the score, more are the BRCA1 and 2 defects, and that predicts the response to platinum-based therapy. And here we use a PARP inhibitors, is a poly ADP ribose polymerase inhibitors, which functions through synthetic lethality. It's a simple thing. It's just that whenever the cell divides, there are a lot of errors in the DNA which accumulate, and they get repaired by two mechanisms. One is BRCA1 and 2, that is by means of homologous recombination pathway. If this BRCA1 and 2 is mutated, the other pathway which runs is a base excision repair. That's what the PARP does. So when you inhibit this, the cells undergo apoptosis and die. So these are just a list of PARP inhibitors which are approved. Another thing I would like to stress here is the PARP inhibitors enhances the immune activation. So it has a synergistic effect. It makes the cold tumor, that is, cold tumor is whenever there is absence or limited tumor infiltrating lymphocytes, into a hot tumor. The next thing is PI3K alteration. So PI3K, that is phosphatidylinositol 3 kinase pathway, is very important. It dictates the cell growth, proliferation, survival, differentiation, and etc. They're class 1 to 3 molecules. You can see here they're intracellular heterodimer. They consist of 2 molecules. Why I'm going to stress this is there's going to be a talk later with this P110. So this subunit is the catalytic subunit. It has 4 units again, alpha, beta, gamma, and delta, and that's P85, which is a regulatory subunit. This in turn activates, phosphorylates PIP2 to PIP3. This causes recruitment of AKT and in turn activates mTOR. And you can see P10 here, which dephosphorylates PIP3 to 2. So that acts as a negative regulator. So almost 40 to 50% of TNBCs have this. So thereby, any of these mutations in any of these would cause resistance to chemo, and and it's also known that they are altered in hormonal receptor positive and HER2 positive tumors. Another pathway, MEK inhibitor pathway, that is MAP kinase and ERK pathway, which joins the same PI3K pathway. And this basically is important, especially when you talk about resistance or taxanes. These MEK inhibitors can be used. So this is just the gist of what I said now. I'm not going to. Okay, next is NTRK mutation. So NTRK mutation is seen in various tumors of adult and pediatric cancers. The TRK pathway is similar to that of any tyrosine kinase receptor pathway. And they're seen more in secretory breast cancers. These are low-grade cancers, are not high-grade, as I mentioned before. And more than 90% are seen in secretory breast cancer, also in secretory carcinoma of salivary gland and other infantile cancers. And the tests used for this are next-generation sequencing, available tests in your lab, IHC, FISH, and RT-PCR. There's just a note on prognostic scoring index using genes. So this is a list of all the tests available: Oncotype DX, MAMA, PRIN, which is used more, Endopredict, breast cancer index, and other things. What we do with the MAMA PRIN analyzes almost 70 genes, and Oncotype DX is what recently people are using this, and it has better prognostic value, late recurrence prediction, and adjuvant chemo and NACT benefits. We can discuss this detail. We can discuss the details in the panel. And what's the solution for Indian patients? It's the CAN Assist. As CAN Assist was the one which we used to send initially, and this is based on the stress response proliferative genes, and they run these 5 biomarkers with 3 other clinical markers. So this is just a list to say that these are the genetic profiles available here, and this is the methodology followed. So I would like to conclude here the talk on triple negative breast cancer, saying that it has heterogeneity. Thereby you can see 6 molecular subtypes, and each molecular subtype has variant pathways, and all the pathways, and each of the pathway has their own inhibitors, and thereby the targeted therapy, making the triple negative positive for treatment. A little bit. I would just to I would like to talk on the ESR1 mutations as well. This is an acquisition of ESR1 mutation is seen in aromatase inhibitor therapy in metastatic ER positive breast cancers. They say that the ESR1 mutations pre-exist in the primary tumors, and it's enriched during metastasis. Thereby, it favors tumor progression. I would like to say in simple words that ESR1, when it's a wild type, causes cell proliferation and amenable to endocrine therapy. But when ESR1 is fused with other fusion partners, they become resistant to endocrine therapy, and that's when they become amenable to CDK4/6 inhibitors. That's what is currently being used. And the molecular journey continues with many more mutations. Thank you for the talk. Thank you. I would like to thank the committee for giving me this opportunity to speak. Thank you all for your patient hearing.
Thank you, Dr. Chaya.
Thank you, sir.
It was an excellent presentation.
Thank you, sir.
You brought out beautifully that there are more targets in breast cancer than just the routine hormone receptors and HER2/neu.
Yes, sir.
The beautiful thing is that there are agents which we can target almost all these new receptors that you have spoken.
Yes, sir.
However, financial toxicity is an issue, but I
Yes.
think that's a topic for discussion in another forum.
Thanks a
Now
lot,
to
sir.
move on,
Okay,
we
sir.
have the next topic, neoadjuvant systemic therapy in breast cancer. There has been a slight change in the speaker. Due to some unavoidable family issues, Dr. Vijay Agarwal could not join. And we are really grateful to Dr. Shekhar Patil, Senior Medical Oncologist at Sri Shankara Cancer Hospital and HCG, who has taken up the challenge and accepted to present at very short notice. I request Dr. Shekhar Patil to proceed with his talk and start the screen sharing. Thank you.
Thank you, sir.
Hello. Hello. Can you hear?
Yeah, we can hear.
My slides.
Yeah. Presentation will be on.
Yeah.
Dr. Chaya, just turn off your screen.
Dr. Chaya, please stop sharing your screen. Yeah, done.
Hello. Yeah.
You can see the slides?
Yeah, I can see it. You can hear, no? You can hear? Yeah. Thank you, Ravi, for this opportunity to be a part of this program. And it is something which I will be discussing on neoadjuvant systemic therapy in breast cancer. As we all know that neoadjuvant systemic therapy is not something new concept. We are practicing it for the last 3 to 4 decades. But over a period of time, it has evolved, and we can see that the outcomes are much better when we use a neoadjuvant chemotherapy because of the better understanding of the breast cancer in some certain subgroups of cancers. Can I have the next slide, please? So if you see the Globocan data, it says that the breast cancer is the highest or the topmost in the list, whether it is global or even in India. In the last 8 to 10 years, it has overtaken the cervical cancer, which used to be our commonest cancer. Now you can see that breast cancer is, if you combine together male, female, and put it into one group, breast cancer is the commonest cancer in India. So all these things because of the urbanization occurring and because of the lifestyle changes, as we are seeing. Can I have the next slide, please? If you see the improvement in the outcomes in breast cancer, you can see definitely there has been in the last, I am there in this practice for the last 3 decades. You can see definitely there is an improvement. We can see the breast cancer mortality has reduced by at least around 10% in the last 2 decades. So this has been an international data. Even in our own experience, we see that a lot of breast cancer patients are doing very well because of the early diagnosis. It may be because of the better understanding and more use of targeted therapies, chemotherapies, and more of a personalized therapies. Because of that, the breast cancer mortality is definitely coming down. Can I have the next slide, please? So as we know that most of the cancers involve a multidisciplinary approach, but more so in the breast cancer because we have got so many choices. We have got endocrine therapy, targeted therapy, now immunotherapy is added, chemotherapy, surgery, radiation, so many options are available. In order to have an improvement in the overall outcome of the patient, we have to navigate through this. We should have some guidelines to navigate through all these choices what we are having it, so that our overall outcome can improve in breast cancer. Can I have the next slide, please? So the neoadjuvant, or more commonly we call it as a pre-operative chemotherapy, because the chemotherapy is the most commonest neoadjuvant therapy which has been used. So what is the goal when you talk of a neoadjuvant or a pre-operative therapy? It should reduce a distant metastasis. When we say it reduces a distant metastasis, it has to improve the overall survival. By doing that, overall survival, whether that is possible or not. Whether the second goal will be to select individualized therapy for a non-responders. If I find some 20-30% of the patient don't respond, I have got any other options. Can I improve the survival in those group of people by identifying them, which may not be possible in the adjuvant setting? Whether we can improve the surgical care itself, whether we can downstage the tumor, by downstaging it, whether we can allow to do a less extensive surgery, or whether we can facilitate the breast conservative surgery, or which can indirectly help in improving the cosmetic outcomes of the patient, so that the overall quality of the patients will be better. So this, with this all the goals in the mind, is neoadjuvant treatment a good option? Let us go through all of these three one by one. Can I have the next slide, please? So if you see that I told you reduce the distant metastasis. Even by using a treatment in an adjuvant setting also, we can reduce the distant metastasis. What is great by using it in the neoadjuvant setting? Because when we use the chemotherapy, earlier in the phase of the treatment, we are attending on the micrometastasis so that the tumor cell kinetics are better attended when you attend the chemotherapy very early. So keeping that in the mind, whether it reduces the distant metastasis, which in turn improves the overall survival. This has to be addressed. This is the theoretical thinking. But whether in a clinical, by in our day-to-day practice, is it possible? We can do it by doing some randomized studies. Can I have the next slide, please? So a large randomized studies was done in the early 2000 where they used the neoadjuvant chemotherapy versus doing a surgery and using the adjuvant chemotherapy. So to looking at the endpoints being the whether there is an improvement in the survival, that is both the disease-free survival and overall survival. That came the basic primary endpoints. In the process, they look for whether the downstaging helped in improving the breast conservation rates. So in this study, they found that there is an increase in the breast conservation from 60 to 68%. The pathological CRs were around 13% in that particular study. Can I have the next slide, please? So as I told you, the endpoints were the disease-free and overall survival. There is no much difference whether you use chemotherapy upfront or after as an adjuvant. There is no difference in the disease-free survival and overall survival. Then why we should use the chemotherapy upfront if the results are going to be same? So that is the question which raised later on, and so it went on into a slowing down in the later phases. Can I have the next slide, please? So even in the meta-analysis, when they did it from the early breast cancer trialist group, when they compared the neoadjuvant versus the adjuvant, they found the breast cancer mortality, disease-free survival, nothing changed. Even in the group which had a neoadjuvant therapy, the local recurrence rates as expected were slightly on the higher side compared to the people where we are used in the adjuvant setting. Can I have the next slide, please? So the second goal, as I told you, by using neoadjuvant therapy, can we individualize the therapy for non-responders? So to address this one also, the same randomized studies looked into it. Can I have the next slide, please? So when they looked into the people who achieved a pathological CR, they did very well. Both their disease-free survival and overall survival in the long run was very good compared to the people who had a partial response or Shreyas, battery kadime alakittu. Battery kadime alakittu. Hello, can you hear? Hello, are you hearing, Ravi?
Yes, sir. Yes, sir.
So the disease-free survival rates were coming down. So because of these things, so there is not much advantage of giving neoadjuvant chemotherapy. Can I have the next slide, please? So if you even in the pathological complete responses as we see it in the long run, particularly in the neoadjuvant chemotherapy when it was used, particularly in the triple negative breast cancer patients, we can see that the responses are much better. Can I have the next slide, please? So the association between the pathological complete response and the event-free survival and the overall survival was much different. If you achieve a pathological CR, the outcomes are going to be very good, both in the long run. That's only if you identify a patient who can achieve a pathological CR by giving a neoadjuvant therapy, at least in the we can tell it can be a surrogate marker to tell that the patient is going to do very well in the long run. So in that way, that particular group of patients can be identified, and the further treatments has to improve to increase the pathological complete response rather than using in an adjuvant setting where we require many years to know that whether that particular treatment is going to be improve the survival. Can I have the next slide, please? So if you see the triple negative breast cancer patients, the hormone receptor patient, if you see the differences are not going to be much. But if you see the triple negative breast cancer or an HER2 positive breast cancer, we see that the pathological CRs are higher. And if the pathological CR are higher, then the overall outcomes in the long run are going to be much better. Can I have the next slide, please? So what we know as of today on the neoadjuvant chemotherapy is, if you achieve a pathological CR, that group of patients are going to do very well in the long run. Their overall survival is going to be very good. So within a short period of time after the neoadjuvant chemotherapy, I can tell a particular patient is going to do well or not. Rather than in adjuvant setting, we have to wait many years to see that one. Patients without a pathological CR don't do that great. But still, can we improve on that one by changing any treatment or adding any additional treatment? Switching the chemotherapy in these poor responders has led to a significant improvement in the survival, which I'll be showing it in next slide. Can I have the next slide, please? So when you give a triple negative breast cancer patient, about 30 to 40% of them achieve a pathological CR. They are going to do very well in the long run. If I have another 60% of the people would have some residual disease remaining, in them the recurrences are very, very high. If you add any additional treatment like chemotherapy, can we reduce the recurrence rate? A randomized study was done in people who didn't achieve pathological CR in triple negative, comparing a capecitabine versus observation, a simple treatment for about 1 year. They found, can I have the next slide, please? They found a significant improvement in the disease-free survival, particularly in the triple negative patient. You can see both the disease-free survival and the overall survival were much, much better. So if I got a triple negative patient, if I get a pathology, even if it is in very early stage breast cancer, I do a biopsy. Why? Because I want to know whether it is a triple negative. If it is triple negative, I would like to give a chemotherapy, because if I achieve a pathological CR, I know that this patient is going to do very well in the long run. And if I don't achieve a pathological CR, at least I got one more option of adding the treatment, which all these things I can miss if I go and directly do a surgery in a triple negative patient. So that's why I strongly feel that giving a neoadjuvant therapy in a triple negative patient is going to be very beneficial to the patients in the long run. Can I have the next slide, please? So using preoperative chemotherapy should be considered for most patients. This is possible, particularly in an early breast cancer, only if you do a particularly biopsy and study it properly. Adding carboplatin in this group of patients has improved the response rates further. And instead of conventional paclitaxel, if you make it as an NACT paclitaxel, we are seeing a higher pathological response rate. So we are seeing this triple negative breast cancer subtype is evolving of a means of going for a personalized therapy. So triple negative breast cancer, we are seeing a better results by using upfront neoadjuvant chemotherapy and making it more personalized. Can I have the next slide, please? So even the NCCN guidelines have suggested that if triple negative breast cancer, after the neoadjuvant chemotherapy, preoperative chemotherapy with taxanes, carboplatin, and after that, if there is a residual disease, capecitabine is recommended even in the people who are on the people who have got some residual disease. This is an NCCN guidelines of 2020 updated. Can I have the next slide, please? So if you use carboplatin, definitely, and nab-paclitaxel, the responses are definitely going to be higher compared to taxanes and anthracyclines. And we see most of the patients use dose-dense adriamycin cyclophosphamide followed by nab-paclitaxel carboplatin, so that we can get a higher pathological responses, so which can be a surrogate marker in the long run in the disease-free survival. Can I have the next slide, please? So let us move on to the HER2 positive breast cancer. Can I have the next slide, please? So even in HER2 breast cancer, it constitutes around 20-25%, which is an aggressive type of cancer, and we have got a very targeted drug now. And when you combine the targeted drug dosimetry chemotherapy with the trastuzumab, that HER2 inhibitor single, or in a combination of trastuzumab and pertuzumab, or only the targeted drug, or only the chemotherapy, and they did a randomized study in a neoadjuvant setting. Can I have the next slide, please? And pathological CR being the primary endpoint of this study, when they combined a chemotherapy with the dual inhibitors, the trastuzumab and pertuzumab, the pathological complete remission rates were quite high. And as I told you, the pathological CR can be a surrogate marker for an improvement in the overall survival. Can I have the next slide, please? So even in that, even in the HER2 positive patient, if you have got a hormone receptor negative, ERPR negative, then the pathological CR rates again climbs up to around 60%. If ERPR is positive and there the pathological CR rate low, compared to ERPR if they're negative, because it makes a more aggressive cancer. So if you have got a patient who has got hormone receptor negative, HER2 positive, better to go for a chemotherapy with a dual HER2 inhibitor, so that which can translate into a high pathological CR, which can translate into an improvement in the overall survival. If you have got a patient who doesn't achieve pathological CR, so again we can escalate the further treatment in the adjuvant setting rather than continuing with trastuzumab with TDM1. Can I have the next slide, please? Can I have the next slide, please? Hello? Hello? Can I have the next slide, please? So if you see the association pathological CR and the hormone receptor, if the patient has got hormone receptor positive, they may not translate into a long-term survival even if you achieve a pathological CR, because the hormone receptor patient continue to relapse because of the hormone receptor driven disease in them. Compared to the hormone receptor negative, they can translate into a significant overall survival. Can I have the next slide, please? So there are a lot of ongoing clinical trials in the neoadjuvant setting by using various novel agents, PIK3 inhibitors, PARP inhibitors, as Dr. Chaya Prasad brought out so nicely on the immune checkpoint inhibitors, which have been used so extensively. A lot of studies are ongoing still in the neoadjuvant setting. I think in the coming days, we may achieve a higher pathological CR. So the role of surgery, whether we should do it or not, becomes a question at that point of time. Can I have the next slide, please? So in the hormone receptor positive breast cancers, the relative efficacy of neoadjuvant chemotherapy is very less. Compared to endocrine therapy, chemotherapy has got almost equal responses. If you see in this one of this study, they show the response rates are almost same. And even the breast conservation was better with the hormone in use. So if you've got a hormone receptor positive breast cancer patient, better go for hormone treatment rather than using a chemotherapy, which may be not that effective with added toxicity, except in some circumstances, which I have mentioned now. Can I have the next slide, please? So if you see a post-menopausal woman who is hormone receptor positive, HER2 negative, neoadjuvant hormone therapy is the best option if it is locally advanced and if you are using a neoadjuvant therapy as an option. If in a premenopausal woman, if HER2 negative, if that is associated with high KIS 67, this is one area where I think a neoadjuvant chemotherapy may be slightly better than the hormone therapy in this particular group of people. If we are using endocrine therapy as a neoadjuvant, don't jump to any conclusion on the response for at least 4 to 6 months to assess for the response. Can I have the next slide, please? So, who should be considered for the preoperative systemic therapy? As we know that in advanced cases, locally advanced, definitely we'll be using neoadjuvant therapy. Even in early breast cancer patient, if the tumor volume is high compared to the breast ratio, if the lymph nodes are clinically positive, there are high risk features like high grade tumor, KIS 67 is high, HER2 receptors is negative, HER2 is positive, hormone receptor, triple negative breast cancer, younger age at diagnosis. So these are all the indications for using a neoadjuvant therapy. And patients who are having early breast cancer, if the tumor size is more than 2 centimeters, if they have a clinically node positive disease, should receive a neoadjuvant therapy so that we can get assess the pathological CR rates and then look at the long-term outcome. Can I have the next slide, please? So to just conclude my talk, why we should administer pre-operative chemotherapy in operable breast cancer. We understand in a locally advanced, we use it, but in operable breast cancer, we use it to downstage the tumor, make it more conservative surgery possible. Even in extent of the axillary surgery can be reduced by bringing it down to some simple sentinel node biopsies. And the pathological complete response in a breast cancer can be used as a surrogate marker. As of today, it is used in the trial basis, but I feel in triple negative and HER2 breast cancer, I think it is going to get translated into a definite survival benefit if it shows a pathological CR. And it can be a predictor for predicting the prognosis in an individual patients of breast cancer, so that each patient, we can say that this patient is going to do well in the first 3 months itself. And subsequently, it will help in guiding the systemic therapy decision. If I have got a patient who has not responded that great, I can escalate my adjuvant therapy with other drugs. As I told you, in HER2 breast cancer patient, if the response is not good, even with dual inhibitor, I would give a TDM1, which has shown a significant improvement in the survival. So that we, by using the neoadjuvant therapy, I feel that we are moving towards more precision, and we are trying to see that which patient to administer what treatment and how long to be administered, where we can de-escalate the treatment, where we can escalate the treatment. All these decisions are possible if you are able to administer a treatment even before a surgeon puts a knife on the breast. Can I have the next slide, please? Thank you. Thank you very much. And thank you, Ravi. Hello. Hello.
Hello.
Are you hearing? Ravi?
Yeah.
Thank you.
Yeah. Thank you, Dr. Shekhar Patil. You have explained very nicely about the why and how of neoadjuvant systemic therapy in breast cancer, and why it is becoming the standard of care, especially in triple negative and HER2 positive cancers. So now we move on to the next topic. It is management of axilla by Dr. Manjunath Shastri. He is a consultant laparoscopic and surgical oncologist at Sri Shankara Cancer Hospital. Dr. Manjunath Shastri, you're there? Dr. Manjunath Shastri? Yeah, you have started sharing your slides. You please unmute yourself and you can start your talk.
Yeah, can you hear me now?
Yeah. Please. Yeah.
Right. Okay. Ravi, am I audible?
You can start. We can see your slides.
Thank you. Yeah. Good evening, all of you. The surgery of breast cancer has seen a sea of change over last 2 centuries. Way back in late 19th century, Dr. Halsted came with the postulation that breast cancer is a local disease and the aggressive treatment was focused on extensive local and local regional surgeries. This led to a lot of mortalities and morbidities. Subsequently, over a period of time, with a better understanding of biology of the cancer, Dr. Fisher came with a postulation that breast cancer is a systemic disease, and with the multimodality treatment and less aggressive surgeries, we could achieve far better results. It is very encouraging to see nowadays that very high cure rates are seen in the early breast cancer. Also increasing, the overall survival is seen in advanced diseases as well. So the motto is less is more. More and more conservative surgeries and more of adjuvant treatment plays an important role in the management of cancer. Sorry. The breast cancer, the cancer of the, sorry. Chaya, can you help me with this? Yeah, it's think of any polar. This one. Okay.
Is the slide moving?
Yeah.
I think you have to see if it is there, you have to click on that enable edit, then it will move.
Manipul. I want to go back. On this one. Okay, here I go. Okay, sorry about this. Now, the surgery of the breast has come a long way from ultra radical surgeries to radical surgery to modified mastectomies. That is what we are doing most commonly now, and to BCS and oncoplastic surgeries. And just lumpectomy alone seen in few selected cases. Similarly, the surgery of the axilla also has evolved from level 3 dissections, which we used to do long ago, to level 2 dissections, level 1 and 2 dissections, and low axillary dissections, sentinel node biopsies, and targeted biopsies, which are off late, and to observation, which is seen in a very small group of patients, particularly elderly people with strong ER/PR positive, and they are having high comorbidities are the candidates where we do the observation alone. The axillary management carries a lot of significance, as the axillary nodal status is very important as a prognostic factor. So this is basically, primary aim is to stage the disease, and secondary to control the local disease whenever it comes back, if at all. Axillary lymph node dissection up to the level 3 is associated with significant lymphedema, neuralgic pain, and shoulder dysfunction. Which is okay. Lymphedema, to bring down this the complications of the axillary dissections, many studies were carried out. One of the most important studies is the NSA-BP B32, which looked into the clinically negative invasive breast cancer patients who were stratified into randomized into two groups. The group 1, which is sentinel node resection followed by axillary dissection, and group 2, which had sentinel node resection, and if they were pathologically positive, they went in for a axillary dissection. Whereas the pathologically negative nodes, no axillary dissection was carried out. In this study, we found out that there was overall survival, disease-free survival, regional control were statistically equivalent in both the groups. So this paved in the path for a more conservative approach to the axilla. There was another important trial, ACOSOG Zoo 11, where we took the early breast cancer patients and treated with a conservative approach, where the lymph nodal burden in the axilla was very minimal. So the positive sentinel nodes, positive by H and E, were randomized into axillary node dissection, and the other group was no further axillary therapy, and both of them went in for whole breast radiation and plus or minus systemic therapy as required. This study closed early because of the low event rates, and demonstrated that the no trend towards the clinical benefit of ALND, that axillary node dissection, for patients with limited nodal disease. Now let us see what are the definite indications for sentinel node biopsy. So all early invasive breast cancers who are clinically node negative, patients undergoing mastectomy for DCIS. In the DCIS, there is another group where you have high degree of dysplasia, or you have extensive microcalcification with the lumps which is more than 5 centimeters. This is another group where we can consider sentinel node biopsy. Thirdly, the axillary staging is used before neoadjuvant chemotherapy. There are contraindications. The only absolute contraindication you see is in inflammatory breast cancer, where the lymphatics are many times blocked because of the disease process. Then relative contraindications are previous surgeries in the axilla or the radiotherapy given to the axilla. But here again, if there is a significant long period of gap between the primary surgery or the RT followed and the next surgery, this can still be considered, as it is seen that alternative lymphatic channels do develop over a period of time. Pregnancy is definitely a relative contraindication because of many issues coming up, like the role of the dye that are used for having a effect on the fetus. So this is a controversial issue. Now, what do we do, or how do we do the sentinel node biopsy in our institution? So here we follow the dual dye technique. What is happening? Okay. Here we use dual dye technique. This we use the blue dye and radioactive isotope. Blue dye is very commonly used because of the easy availability and low cost. Yes, it does have some degree of complications like allergic reactions, and if it is given close to the skin, sometimes necrosis of the skin is also noticed. Isotope, radioactive isotope, what we use here is a technetium 99 labeled nano particles, which we are using here. And yes, it has to be available, which is an issue, or even in a city like us, there are only few centers who are doing this. And indocyanine green, and these are the new techniques that are available is super paramagnetic iron oxide nanoparticles and contrast enhanced ultrasound using micro bubbles. These are all newer techniques which need more validations. So in our institution, when the patients come for the sentinel node biopsy, they report to the nuclear medicine department early in the morning, and they're given the radioactive isotope peritumoral and also in the periareolar region, and the nuclear scan is taken to pick up the node, the hot nodes, and then they are shifted to the operation theater. And on the operation, in the operation theater, I visually look into the activity of the isotope by using a gigameter and a gamma probe. And first see the primary activity, and that also next in the axilla we check about the activity of the lymph nodes. And once the patient is induced, we do give a 3 cc methylene blue is injected into the subareolar region, and after about 10 minutes the axilla is the surgery is started. Now, usually we use the gamma probe to locate the hot node or wherever the maximum activity is seen. We make an incision roughly over it, and as you dissect, you can identify the lymph node with the blue dye, and also the using the gamma probe where the activity is picked up. So once the lymph nodes are identified, they are picked up, and at least 3 lymph nodes are identified and sent to the pathology department. In our pathology department, they do the frozen sections, which takes about roughly about 20 minutes to be reported. And once the report is given as negative or positive, we decide, depending upon the many factors, we decide as to whether to go ahead with the sentinel further with the ALND or no further dissection of the axilla. Now, usually the lymph nodes are made into multiple sections of 2 millimeter size each. If the metastasis is more than 2 millimeters, it is called macrometastasis. And if it is less than 2 millimeters, it is micrometastasis. And there are clusters of cells seen, tumor cells seen, then it is called the isolated tumor cells. The patients with micrometastasis and isolated tumor cells, there is no need of further axillary node dissection. Now, there is another entity called low axillary dissection or low axillary sampling. As we discussed little earlier, the nuclear medicine department is not well established in many of the institutions. Even if it's a city, there are few institutions who have this facility. Secondly, the frozen section facility also is an important thing which is not available everywhere. Thirdly, the pathologist who can confidently report on a frozen section is also limited. To add to all this, in our scenario as economy is an issue, patients coming with severe financial constraints, adding few more thousands of rupees for a sentinel node biopsy is also an issue to be considered. So in these scenarios, there is a role of low axillary dissection. So basically, most of the sentinel nodes are seen in this area, which is formed superiorly by the intercostal brachial nerve, laterally by the thoracodorsal pedicle, inferiorly the angular vein, and medially you have the serratus anterior and serratus and nerve to serratus anterior. We dissect in this area and pick up the nodes that are there and send it for further testing. Axillary node dissection, this is the classical axillary node dissection that's done. See the limits, superiorly you have the axillary vein and laterally the thoracodorsal pedicle, inferiorly the angular vein, which you can see, and medially the long thoracic nerve. Avoid the dissection lateral to the thoracodorsal pedicles to avoid the lymphedema. Now, the role of sentinel node biopsy in early breast cancer is well established. There are no doubts about it. But the issue that comes up is what is its role in neoadjuvant setup? Now, as we see that more and more breast cancer cases are going in for neoadjuvant therapy, and the assessment needs to be made as to what is exactly the role of sentinel lymph node. There are few trials that went into this issue. Important trial is the Sentina trial, where the clinically node negative patients were taken up for sentinel node biopsy, and one arm went into the pathologically node negative, received neoadjuvant chemotherapy, followed by no axillary lymph node dissections further. This was into the arm A. The second arm was pathologically node which were positive, also went in for neoadjuvant chemotherapy. They again went in for sentinel node biopsy and axillary node dissection. The third arm was a clinically node positive N1 and N2, but they did not have any sentinel node biopsies done earlier, went in for neoadjuvant chemotherapy, and there we had a conversion to clinically node negative disease. Here they went into sentinel node biopsy again and followed by axillary node dissection. The fourth arm was the disease remains in the clinically node negative, node positive, and they went in for a axillary node dissection. Now, the focus was mainly on this arm B and arm C. So the detection rate in arm B was 60% and the arm C was 80%. And the false negative rates in arm B was 51% and that arm C was 14%. So in this, we came to the derivation from this was after the systemic treatment, after the systemic treatment or early lymph node biopsy, the procedure has a low detection rate and a higher false negative rate compared to the sentinel node biopsy done before neoadjuvant chemotherapy. So basically, it suggested that we need to do lymph node biopsy after the neoadjuvant chemotherapy. So, but the people who were putting forward this theory of neoadjuvant, the sentinel node biopsy before neoadjuvant chemotherapy said that they could have the idea about the pathological status of the axilla before NACT. The other issue that comes up in a scenario where neoadjuvant chemotherapy is given and then the sentinel node biopsy is done is that there are poor identification of the sentinel node due to alteration in the lymphatics. And there's a high false negative rates due to varied effect of the NACT on the sentinel nodes, on the non-sentinel nodes. So it is possible that many of the sentinel nodes might be cleared of the pathology, but may still have disease in the sentinel node, non-sentinel nodes. So it is clear that sentinel node in clinically N0 is a feasible treatment option. Additional axillary treatment is not necessary in node negative, who are on node negative in sentinel node biopsy. But sentinel biopsy in clinically N plus is to reduce the false negative rates in this set of people. We have to put clips or the beads into the node positive cases. Then came this AMAROS trial, which was basically done to avoid the morbidity associated with axillary lymph node ILND, and this trial assessed whether radiotherapy provides comparable regional control with fewer side effects. Here again, we had a small 0.5 to 3 centimeter invasive breast cancer lesions, which were clinically negative. They were taken and sentinel biopsy procedure was carried out. Those who were negative on sentinel node had a follow-up, and the sentinel node positive cases went in for ALND or axillary radiotherapy. About a 6.1 year follow-up was done, and 5-year regional control did not differ in the both groups. Lymphedema was about 28% in ALND and 14% in the radiotherapy group. Basically, it suggested that it is a radiotherapy is not in no way inferior to the axillary dissection group. Now, to summarize, how do we treat a patient who comes with the comes to the hospital with their nodal disease? When it is N0 or suspicious 1 or 2 lymph nodes on a triple assessment, we go ahead and do a sentinel lymph node biopsy. If the node comes, the sentinel node biopsy comes negative, there is no need for ALND. If it comes positive and there is micrometastasis, then also there is no need for ALND. Third group, where you have a positive sentinel node, but you have the ACOSOGOG 00ZOO11 T1, T2, and 1 or 2 lymph nodes on SLNB. And those patients should undergo BCS and breast radiation, whole breast radiation, and no NACT. If all these factors are included, then if it is positive, if they all are accepted in this group, then there is no need for ALND. If they don't fall into this group, then we should go ahead and do the axillary node dissection at level 1 and level 2. The other group where you have little more nodal disease, what we call clinically node positive, which are more than 3 nodes, and tumor T2 and more, or lymph nodes more than one. So this is a group where you do a FNAC or a core biopsy which comes positive. And if it is positive and the category is not growing into the NACT, then you can go ahead and do the axillary node dissection. But if this group is going in for a neoadjuvant chemotherapy, then it is you have to give following the NACT, we assess the axilla again. If there is a residual nodes seen, then you have to go and do the axillary node dissection. And if suppose there is a clinically N0, there are no nodes noticed in a post NACT, then you can do SLNB or axillary node dissection. Lastly, when we come to the assessment at the Indian scenario, most of these studies, whatever we have seen, is done in Western world, where the disease burden is usually less. The small primary tumors are small, and the axillary nodes are also small compared to whatever we see in India. Also, the aggressiveness of those tumors are also less. Here in India, we see quite advanced lesions, and they are more aggressive, and multiple axillary nodes are seen, and which are also quite huge in size, and more triple negative diseases or more aggressive diseases are also seen. So we actually have to have more studies in India and try to have some protocols for our own set of patients. Here with this, I end my talk. Thank you. There's nothing coming.
Hello.
Hello.
Thank you, Dr. Manjunath Shastri. You have very lucidly brought out the concept of sentinel lymph node biopsy, especially in patients who have undergone neoadjuvant chemotherapy. And also you have told what to do in a setup where sentinel lymph node biopsy is not available. Thank you. I request all the participants to post questions in the chat box. We can discuss about them later at the question answer session. Now moving on, we will. I request Dr. Karthik to speak about recent concepts in breast radiation. He is a consultant radiation oncologist at Sri Shankara Cancer Hospital. I request the speakers to stick to their time as we are running short of our target. Thank you. Dr. Karthik.
Good evening, sir. Am I audible? Am I audible, sir?
Dr. Karthik, you can hear?
Yeah, I can hear you, sir. Am I audible?
You have to unmute yourself and start.
Yeah, you're audible, sir.
Yeah, okay. So thank you for the organizers for giving me this opportunity to talk on the recent concepts in... hello? Hello?
Hello.
Am I audible?
Yeah, sir. You're audible.
Please proceed.
Yeah. Okay. My topic is recent concepts in breast irradiation. So what is the story so far as radiotherapy is concerned? So we know that initially it was all MRM, but now with BCS and radiotherapy, it was shown that the overall survival and local recurrence was the same as compared to MRM. BCS alone showed that there is a significantly increased local recurrence, but when you add radiation to it, it is the same as modified radical mastectomy. And the large EB-CT-CG analysis showed that lumpectomy plus RT decreases not only the local recurrence, but also has an impact on the breast cancer survival. As far as post-mastectomy radiation is concerned, excuse me, sorry about this. I'm sorry, there seems to be a technical issue. Yeah, so as far as post-mastectomy radiation is concerned, the indication for radiation is for larger tumors, T3, T4 tumors, more than 4 positive axillary lymph nodes, involvement of supraclavicular or internal mammary, and there's a strong consideration for PMRT and regional lymph nodes and 1 to 3 nodes. For T1 N0 patients, PMRT is generally avoided. So the current standard of care for early breast cancer is BCS plus RT. The standard has been 50 gray in 25 fractions with boost to the lumpectomy cavity. But now the question is, what next? So the focus now in radiation is to reduce time and to reduce the volume of treatment. Let's see how that is being done. The UK START trials were one of the earliest trials that looked at reducing the number of days of radiation. So from 5 weeks, oh, I'm sorry, there's an issue here. So the early trial of the UK START trial showed that from 5 weeks, they could reduce it to 3 weeks. There were 2 trials, the UK START A and B trials that looked at 41.6 gray and 39 gray in 3 weeks. So the same as the UK START B looked at, oh, I'm sorry about this. I think there's an issue with the system here. It just goes on. Yeah, so sorry about the technical problem. So the START A and B trial showed that the number of fractions could be reduced. And the main conclusion of that was, excuse me, sorry about this. Yeah, yeah, sure. can do that talk next time. It just goes ahead on its own.
Because I spoke to this one going off.
It goes.
No, it happened to even so, but I did it from the same system.
Yeah, I don't know what is the issue. Anyway.
We'll do one thing. We'll just shut down entirely and open because I did it from the system. It is already animation.
Yeah, I have animation. Maybe because of the animation.
Yeah.
There's a problem.
Even sir had, I think, animation. Because I didn't have any animation.
In this, can we try
This
now?
you can. It's not saying that. Because all of our systems have. No, it's going on. It's going on.
Hello.
Just 1 minute, sir.
Can we ask Dr. Prashant Kesri to speak?
Next speaker can speak.
Yeah, and then Dr. Karthik can get ready by that time.
Yes.
Okay.
Prashant Kesri, sir.
I'm extremely sorry because there were some technical issues. Dr. Karthik cannot continue with his talk now. He will do it next. Now, in the meantime, I will ask Dr. Prashant Kesri, reconstructive and plastic surgeon at Sri Shankara Cancer Hospital, to start his presentation on reconstructive techniques in breast cancer. Dr. Prashant, welcome. Please start sharing your slides and you can start. I think you have to unmute yourself. You're audible. You have to slides.
Am I audible? Can you see my screen?
Yeah, you're audible. No, slides are not seen. You have to share your screen.
Yeah, my share screen I'm pressing, but I think it has to be allowed.
Hello.
Hello.
Dr. Karthik, stop sharing your screen.
I think my screen has to be allowed separately.
Yeah.
Dr. Karthik's screen sharing is off.
Yeah.
When I press my screen share the screen option, I'm going to basic, advanced, and files. Anybody from the technical team can help? It is not. I'm unable
Mr.
to share
Sachin,
the screen.
Are you there?
Yeah. Can you just open the PPT, sir,
share
in the
the
background?
slides?
Sorry?
Can you open the PPT in the background, sir? First, open the. Yeah. Just open the PPT in the background, then click on share screen.
Hmm. Hmm.
Hello, is it visible, please? Hello?
No, sir, it's not visible. When you click on the share screen, the window of it's coming. Just full screen it, sir.
Oh, it's a Mac.
Yeah, it's visible now. It's visible now.
Good evening, everyone. Dr. Prashant Kesri, consultant plastic surgeon with Shankara from the beginning. And I thank everyone for giving me this opportunity to present reconstruction options in the breast cancer surgery. One of the most commonly practiced option after breast resection is not to reconstruct at all. Lot of patients compared to the Western statistics go without reconstruction, and many of them don't even use an explant like this. I always wonder, why should we do breast reconstruction after mastectomy or breast conservation surgery? If we reflect upon our culture, the importance of breast and its importance to one's psyche and as a physical form and to their parents is immense. We recite Samudra Vasane Devi Parvatastana Mandale, but we don't give that much importance to the breast to be reconstructed after it is removed in respective ladies. So, if breast reconstruction can give so much confidence, and power to bounce back in this lady's career, isn't it fair to offer breast reconstruction to everyone who undergoes its resection? That's a big question. And there are numerous studies citing that recovery and mental health, confidence, depression rates are much better when the reconstruction is done after resection. Should we wait for such cases when this lady had suffered for almost 1.5 years without a non-healing ulcer on the chest and could have been simply solved with a latissimus dorsi myocutaneous flap? And another example of this elderly lady who was 85 years, who was not fit for general anesthesia, but her only wish before she died was to get this wound on the chest covered. So we did this surgery under paraspinal epidural block, and a simple thoracodorsal artery perforator flap could make her wound free. And after this, she lived without a wound for about 7 years. There are various options. I would like to just briefly touch upon everything, giving a bird's eye view so that we have our options and priorities right. When a subcutaneous mastectomy like this is done, if the cyst or the gap that has to be filled is small, we can just manage with structural fat grafting, which is harvested from other parts of the body. We have done a series of 50 fat graftings post breast conservation surgery and large cyst excisions. Results are very good, and initially we used to have problem of calcification on radiograph, which is not there now. And another option is to use alloderm or a acellular dermal matrix and an expander behind when subcutaneous mastectomy is done, and to replace the expander when the volume attained is adequate, like we have done in this case. As breast conservation surgeries are increasing, I think the reconstruction surgeries increase, because just doing breast conservation BCS and to give a result like this is just not acceptable. I many times feel that these patients are better off with total mastectomy and an explant. There are various options to replace or displace the volume which has been removed during breast conservation surgery, like this one. And when the volume that has to be replaced is more than what can be managed with a oncoplastic surgery, then we bring in tissues from other areas of the body. One of the most common areas that we use is latissimus dorsi. This used to be the workhorse of breast reconstruction in the last 2 decades. Now it is being overtaken by DIEAP flaps. And many times, like, we hear that breast reconstruction can't be done because patient can't afford it. Why I have put this picture is the amount of additional expense we have incurred in this patient is just an extra set of sterile drapes and an increase in operative time of just about more than an hour's time. And the results and the healing time that is reduced is really fast. And latissimus dorsi with implant has been another mainstream of reconstruction in our center. Just sliding through various operative steps where this is the amount of skin loss and the breast loss, and we have placed a sizer, and to match that size, we have taken latissimus dorsi entire muzzle and a skin paddle, and along with the appropriately sized implants. This is at the end of inset of the muzzle flap, and a fairly good volume match as well as covering of the skin soft tissue defect which was there. And patient went to radiation as like there was no delay in radiation because of reconstructive surgery, because healing was very fast. This is another patient with latissimus dorsi muzzle with implant, and we offered her reduction in the left side of the breast, but she refused. And now the workhorse of our reconstruction is slowly DIEAP flap. That is a perforator flap, which we all know, which is based on deep inferior epigastric artery. Advantage is this tram muscle is also spared and there is no weakness in the abdominal wall. And we plumb the blood vessels which are based on this tiny perforator to the internal memory vessels. And this is how we mark the perforator before we harvest the flap, and we get an accurate estimation of what volume has to be replaced. In Shankara, we have been trying this innovative method of marking the perforators using a CT scan. Sorry, the video is not playing. We are using lympho-CT scan to mark the perforators so that we are trying to replace mandatory spiral CT, which is done in Western countries before DIEAP flap. This is how a DIEAP flap, which is done for breast reconstruction, looks like. There is an excess volume because of edema and that settles down. Here, there are no implants used and patient gets a flat abdomen. Another DIEAP flap done for right breast reconstruction. Only complaint the patient had was what stretch marks she had on the abdomen are now seen on her chest. Otherwise, she was very happy with the form and the fullness it provided. Many times, opposite breast reduction is mandated to match the volume, and this doesn't delay the initiation of radiation, and it gives immense increase in patient's confidence. Nipple areola reconstruction usually is done after 6 months to 8 months after breast reconstruction. I'd like to passingly mention a few flaps which we don't do in our population but are quite popular in Western population because of requirement of smaller breasts to match, is called S-gap and I-gap perforator flaps. This is a standard way how nipple is constructed, and areola we prefer to do a thin skin graft to match the areola color, and many times it can be tattooed also. What we all have to ask is, when our scripture and when our culture had lot of importance to perfect form and function of breast, why don't we do a good reconstruction and offer them an option to have a good body image and to bounce back to their normal life, not only physically but also mentally. And in today's age, people are asking for enhancement of their existing breast size and reduction in their breast size, and even people come for lifts of 2 to 3 centimeters. In such situation, if we don't offer reconstruction when we are removing the entire breast tissue, I think it's a crime not to offer them a breast reconstruction option. So each patient will have is like a lock and the key, and it is as a team we have to discuss which would suit her situation the best and to give her the best reconstruction that is possible. In Shankara, we are offering all possible options like perforator flaps, oncoplasty flaps. We are offering latissimus dorsi with implant, without implant, and we are also planning to start lymphedema services, because a breast reconstruction done and the arm goes for lymphedema and we don't take care of it is an incomplete treatment. That's what I feel. So we are starting lymphedema services, which includes a team of physiotherapists and advanced imaging this one, and we'll be offering both free omental transfer as well as lymphovenation shortly. As I said, each breast cancer reconstruction is like a lock and key, and with reconstructive surgeons, with oncosurgeons, we need to plan which key suits the lock perfectly. And in anywhere in the world, the importance of a properly beautiful formed breast can't be overemphasized. And breast reconstruction, when planned properly, executed nicely, gives fantastic results. breast reconstruction will not be a burden, but it will be like a floating balloon which lifts up the morale and confidence of the patient. Thank you very much for giving this opportunity. I conclude my talk.
Thank you, Dr. Prashant. You have very nicely illustrated that with reconstructive techniques that are available presently, women need not worry about poor cosmesis, either because of mastectomy or even in breast conservation surgery. It was really indeed very nice. So we move on to the next topic. Is Dr. Karthik ready?
Yes, sir. We're ready with this slide. Yes, sir. I'm ready, sir.
Dr. Karthik, you're ready?
Dr. Prashant has
Karthik,
to stop sharing his slides, sir.
Yeah. Dr. Prashant, kindly stop sharing your slide. Now you can share, sir.
Dr. Karthik is ready to begin his presentation on recent concepts in radiation in breast cancer patients. Karthik, you have to unmute yourself and start sharing the screen. Yeah.
Can you see the screen, sir?
Yeah, we can see the screen.
Full screen.
Okay.
Yeah. Perfect.
Okay.
Yeah. Please proceed. Yeah.
Okay. Apologize again for the technical problem. Sorry, just 1 minute. So let me, I'll talk like that. Yeah. So the story so far is that, as I was saying, the standard of care earlier has been mastectomy, but it has been shown that breast conservative surgery with radiation had equal results. Local recurrence alone with BCS alone was significantly increased, but with the addition of radiation, it was seen that the results were equal to that of mastectomy. The EBCTCG analysis showed that the lumpectomy plus radiation not only reduced the local recurrence, but also had an impact on the breast cancer survival.
So could you full screen it?
No, if it there's a problem if I full screen it. That's the reason. Yeah.
Okay.
So post-mastectomy radiation, the indications have been for larger tumors, T3, T4, and more than 4 positive axillary lymph nodes, involvement of supraclav or internal mammary nodes. And there's a strong consideration when there is, for post-mastectomy radiation, when there's 1 to 3 nodes. For PT1 and 2 with no nodes, PMRT is generally avoided. So we have seen that the standard has been BCS with radiation, and the older schedule has been 50 gray and 25 fractions with a boost, which came up to around 6 weeks of radiation. So the investigators and the physicians thought as to what next could be done. And the way forward was to either reduce the time of the radiation or to reduce the volume. The UK START trials were one of the earliest trials that looked at reducing the duration of treatment. There were 2 trials, the START A and the START B, and recently the 10-year follow-up results of the 2 randomized trials were published. And it was seen that they looked at reducing the duration from 5 weeks to 3 weeks, and the trials showed that hypofractionation is safe and effective. And they concluded that it is better to support the continued use of 40 gray in 15 fractions. One of the worry that radiation oncologists had by increasing the dose per fraction and reducing the overall treatment time was whether it would have an effect on the normal tissue effects in the breast. But again, the meta-analysis that was done that looked at the normal tissue effects showed that there was a favorable effect with increasing the dose per fraction. So at the same time, there was a Canadian trial which also looked at hypofractionation. Timothy Whelan and the group looked at giving 42.5 gray in 16 fractions hypofractionated regimen compared with the standard regimen of 50 gray in 25 fractions. and they found that there was no difference in breast recurrences, cosmesis, or grade 2 and 3 toxicity. Similarly, there were other trials also. So based on these trials, the ASTRO came up with recommendations in 2011. The guidelines, but that they presented in 2011, they were very cautious with what they said about hypofractionation. They said age had to be more than 50 years, stage had to be T1, T2, no chemotherapy, and dose homogeneity to be plus or 7%. But now, with more studies coming in, data being more matured, the 2018 guidelines showed that any age, any stage, provided the whole breast had to be treated, any chemotherapy, and volume of breast tissue receiving more than 105%. So there is a significant shift in the last 7 to 8 years, and people have started accepting the hypofractionation. So as of today, 40 gray in 15 fractions or 42.5 gray in 16 fractions with a boost has become the standard. So now people started thinking, can it be reduced further? We started with 5 weeks of radiation, then we moved to 3 weeks. Can the duration be reduced further? So the first one of the earlier people to look at just giving 5 fractions of radiation was Murray Brunt and his colleagues, and they compared 3 fractionation of 50 grain 25 fraction, 30 grain 5 fractions, and 28.5 grain 5 fraction. The 5 fraction schedule were given once a week in what is known as the FAST trial. They saw that the normal tissue effects were higher after 30 gray and 5 fractions, but there was no difference between the 28.5 gray and 50 gray in 25 fraction. The main thing was there was no difference in the ipsilateral breast cancer recurrence. So based on this, the investigators were able to find a schedule which was comparable to that of the normal schedule. But the problem with this was it was a once in a week schedule. So the total duration was still up to 5 weeks to 6 weeks. So following this, the same investigators then came up with the much talked about fast forward trial, which instead of once a week regimen, they gave it in 5 days continuously. This became very popular as this was published during the COVID pandemic, and physicians were very keen to lap it up so that you could finish the treatment quickly. This is again a phase 3 trial, and they compared 40 grain 15 fractions with 27 grain 5 fractions and 26 grain 5 fractions. The ipsilateral breast recurrence between the three were same. The hazard ratio for 27 gray was 0.86 and for the 26 gray was 0.67. But the 27 gray and 5 fractions had more toxicity in the long-term in the follow-up as compared to 26 gray. So based on this, they recommended that once a week is non-inferior to standard of 40 gray and 15 fractions over 3 weeks, and it was safe in terms of normal tissue effects up to 5 years for patient prescribing adjuvant local radiotherapy. The main conclusion was there was a major benefit in terms of convenience and cost for patients and for health services globally. So this is now many physicians have tried it out. They have done 26 gray and 5 fractions, but there is some caution as long-term results with high dose per fraction is still awaited. Now that we have reduced the time from 5 weeks to 3 weeks now to 5 days, let's see if we can reduce the volume of radiation that was given. So we now know that breast cancer is not a single entity. It has molecular subtypes, the luminal A, luminal B, HER2, and triple negative. So in this era of systemic therapy and subtyping, age still continues to remain a prognostic factor. So once this subtyping came about, the Swedish breast cancer group tried to see if radiation had any effect on the individual subtypes. And the Swedish breast cancer group 91 trial looked at the effect of radiotherapy on the subtypes, and they saw that the HER2 positive tumors seemed to be the most radioresistant, and the triple negative had the highest death from breast cancer. But what they also noticed was that the luminal A subgroup was very low risk. So when BCS and radiation was added to luminal A group, very low risk of recurrence. So then people started thinking, can we reduce the radiation volume in these patients who have a very low risk? So the ways to do that were with APBI, with IORT, or even no radiation at all. So what is APBI, or accelerated partial breast irradiation? This is delivery of hypofractionated radiotherapy to tumor bed with margin, because this area is considered to be at the highest risk of recurrence. This is usually done within a week after lumpectomy, and the whole treatment is finished by 6 to 10 fractions. There are many methods to do APBI. I am not going to go into the details of those, but broadly they are divided into the brachytherapy technique, intraoperative, and external beam. So if you look at this graph, which is from the Jayant Vaidya's target paper, there is so much data now available on APBI, and there is a large follow-up also. So many people are now trying to see if APBI can be made standard in many places. So even the Astro APBI update published 3 years ago changed from what they initially published in 2009. The original recommendation was APBI could be done more than 60 years, but now it has been brought down to 50 years. Tumor size less than 2 centimeters, margins negative. Earlier, DCIS was not allowed, but now the latest update says that even for DCIS, it can be done. ER positive, PN0. In these subset of patients, APBI can be done. But is APBI non-inferior to whole breast irradiation? There are many trials, out of which the most common are the import load trial and the recently published rapid trial and the NSABP B39 RTOG 0413. So the import load trial looked at 3 schedules, 40 gray in 15 whole breast with 36 gray in 15. That is, you reduce the whole breast radiation, and also a partial breast receiving only 40 gray in 15 fraction. So if you look at the 5-year cumulative incidence of locoregional recurrences, for the low dose and for PBI, they were very low. So this showed that there is that partial breast irradiation was non-inferior. So similarly, 2 other trials were published last year. One was the rapid trial, which compared the 16 fraction versus 10 fractions of APBI. The ipsilateral breast tumor recurrence was equivalent, but there was an increased late toxicity in the APBI arm. Similarly, the NSABP trial again compared 50 gray and 25 fractions with 10 fractions of APBI, and they found once again that the ipsilateral breast tumor recurrence was low but had higher toxicity. But it's interesting because these 2 trials, although they looked at the same thing, statistically the way they were designed was different. The NSABP trial was designed for equivalence, whereas the rapid trial focused on non-inferiority. And since they all received a boost, NSABP received about 80% of the patients received boost, so there was more toxicity. And the rapid trial, they gave the APBI twice a day. So these could be the reasons for late toxicity. But based on the evidence, we can say that APBI is non-inferior to whole breast post-lumpectomy, and it can be used in these set of patients 40 to 50 years, stage 1, node negative, ER positive, PR positive, and grade 1 to 2 tumors. The next is, what is intraoperative radiotherapy? Here, as soon as the tumor is removed, you give radiation to the lumpectomy cavity. The advantage is that there is a direct visualization of the tumor bed and very localized radiation there is, and it reduces the time. The final pathology, of course, is not known, and that is a disadvantage. You need special equipment. There is increased OT time, and long-term results are still awaited. So there were 2 trials that I like to mention. One is the Elliott trial, which compared the standard of 50 gray 25 fractions with 21 gray boost, and look at the recurrences in the Elliott arm. So the IBRT in quadrant and outside the quadrant recurrences were very high in the Elliott arm. Similarly, the target IORT trial by Jayant Vaidya group, they again looked at a large number of patients where they randomized to target IORT and EBRT, and the radiation was given immediately after lumpectomy, and they had a 2.1% recurrence in the target arm as compared to 0.95 in the arm. But what were the problems with IORT? The problems were that most of the patients underwent treatment before the final pathology was known. So as a result of this, 17% in the target arm and 5.5% in the Elliott received external radiation later. So, but this is still can be considered as one of the methods for treating a low risk disease. Now we look at whether we can omit radiotherapy completely for the luminal A disease. The NCI Bold CISNET collaboration, they pooled data from 7 trials for low risk cancers. And what they saw was there was no difference in the overall survival, but there definitely was a 2.5-fold increase in the loco-regional and distant recurrence. So they concluded that omission of radiotherapy in hormone sensitive patients with low recurrence risk may lead to a modest increase in loco-regional recurrent rates. So as of now, we cannot omit radiotherapy for these groups. There is a phase 3 trial that is looking at de-escalating radiation based on the oncotype DX value of less than 18. The results of that will be awaited. Now, in a post-mastectomy setting, the controversy of nodal irradiation has always been there, especially in the 1 to 3 positive group. More than 4 is a definite indication, but for 1 to 3 nodes, there was controversy. But the EBCTCG analysis showed that with nodal irradiation, there's a 16.5% gain in local control. Also, there is gain in overall control and nearly an 8% improvement in the 20-year survival. Now, this graph shows where it is of maximum benefit. At the far left, you have the highest risk where systemic therapy is not given. In this group of patients, there is no point in doing a loco-regional radiation because the survival is going to be very poor. Whereas at the far right, you have a low risk group of patients with effective systemic therapy where de-intensification could be tried. But majority of the patients fall in between these two where the maximum benefit is seen with regional nodal irradiation. Post lumpectomy, again, 2 trials looked at nodal irradiation, the NCIC MA20 and the URTC 22922. And what they saw was with nodal irradiation, the loco-regional recurrence decreased by 3%, distance-free disease and disease-free survival and overall disease-free survival improved with loco-regional recurrence. Loco-regional nodal irradiation. So what they concluded was that by irradiating the regional nodes, there is a systemic effect, not just a loco-regional effect. There is some controversy as to internal mammary nodal irradiation. The DBCG study, a population-based cohort study, looked at irradiating the internal mammary nodes, and they saw that it increased the overall survival in patients with node-positive breast cancer. But they also noticed that the effect was maximum when many nodes were involved and those who had a medial or a central tumor. It did not increase the ischemic heart disease rates in the 2 groups. With the modern technology available and the kind of radiation that we do, it is safe to do IMN without increasing the toxicity. As we know now that most of the patients go in for an oncotype DX, but what we are also seeing is that the oncotype DX are also predictive for loco-regional recurrence, as is seen with this trial. They saw that these kind of findings can have an implication on whether radiation can be used if the oncotype DX score is more. The CCTG MA39 Taylor RT trial results are awaited, where they have randomized based on an oncotype DX. Based on this score, they are randomized into whether nodal irradiation can be done or not. And this results will be very interesting to see whether we can routinely use oncotype DX and then decide whether nodal irradiation can be done. What is the role of RT post neoadjuvant CT? This is the URTC data. I think Dr. Patil also referred to this. And in this, there is a high rate of recurrence in certain group of patients, like in TNBC, in HER2-neu without trastuzumab, and in HER2-neu positive patients. But the main or the most recurrence was seen when there is a lack of pathological response to neoadjuvant CT and if there are more than 4 positive nodes. So based on this, there is, although there is no prospective data, we still use radiation post neoadjuvant, especially if there is a lack of pathological response and more number of nodes. So today we, for clinical CN0, pathological N0, maybe there is a case for observation, but in other situations, it is better to do regional nodal irradiation. The NRG, NSABP trial results are awaited for role of RNI post NACT. So to summarize my talk, addition of RT to BCS continues to remain the standard of care. Hypofractionated radiation of 40 gray in 15 fractions and boost is well accepted. There is a trend towards further reducing the duration of RT, especially with the fast forward trial. APBI can be considered in a very select group of patients, and regional nodal irradiation post mastectomy node positive cases has systemic benefits, and there's more data is needed for standardizing radiation post NACT. Thank you very much for a patient hearing.
Thank you, Dr. Karthik. You have comprehensively explained the concepts of radiation in a scenario of breast cancer. Now, without further delay, we move on to the next topic as we are running late. I request Dr. Ravi Tippeswamy, consultant medical oncologist at Sri Shankara Cancer Hospital, to speak on picking the right strategy for treating patients with hormone receptor positive, HER2 negative, PI3K positive metastatic breast cancers. Dr. Ravi Tippeswamy, you can proceed.
Dr. Ravi, are you unmute?
Dr. Ravi, you unmute yourself and start. Your slides are there.
Slides.
Dr. Ravi?
Yeah, yes, sir. I'm just unmuting. Yeah. So, good evening, everybody. So, today we'll just discuss about some of the newer options what we have in hormone positive, HER2 negative with PIK3 mutation breast cancers. So, as we all know, PIK3 mutation is the most commonly mutated gene in hormone positive, HER2 negative advanced breast cancer. So, it contributes roughly about 40% of the incidence. So, why we have to know about PIK3 mutation? Because when we identify PIK3 mutation, it is a negative prognostic factor associated with poor response to therapy and worse overall prognosis. So, this has been studied in various meta-analyses, and it has been proved that PIK3 mutation acts as both predictive and prognostic biomarker. So, knowing the PIK3 status upfront in an advanced hormone positive HER2 negative metastatic breast cancer helps a clinician to predict how a patient will behave to endocrine therapy. Generally, when we detect PIK3 mutation, in the back of the mind we know that they will not respond well to endocrine therapy because it suggests endocrine therapy resistance. So, knowing the PIK3 status helps us for planning further treatment. So, when we identify PIK3 mutation, now we have got targets. So, targeting PIK3 mutation will overcome the resistance to endocrine based therapies. So, this PIK3 mutation, the alpelisib drug, came to the clinical practice based on the SOLAR-1 study. So, SOLAR-1 study is the first phase 3 trial. It's a randomized, double-blind, placebo-controlled phase 3 trial for alpelisib. The inclusion criteria was post-menopausal women, and also men were included here. Hormone positive HER2 negative advanced breast cancer. They should have progressed on an AI therapy or recurred after an AI therapy with PIK3 mutation identified by either tissue or in blood. They were randomized to either fulvestrant with placebo or fulvestrant with PIK3 inhibitor, that is alpelisib. The primary endpoint in the study was progression-free survival, and the secondary endpoint in the study was overall survival, objective response rate, safety and clinical benefit. if we see the results, when we add PIK3 inhibitor to fulvestrant, the median progression-free survival almost doubles. So the median PFS in the study was 11 months as compared to 5.7 months in the control arm, which suggests that adding PIK3 inhibitor to fulvestrant definitely overcomes the endocrine therapy resistance. So based on this, the FDA gave approval for the alpelisib. If we come to subgroups in PFS, whether some subgroups benefited or some subgroups did not benefit, so the results were consistent across all major subgroups, whether you take bone-only disease or visceral disease. If we come to the overall survival data, the median overall survival in the study was 39.3 months, and numerically it was 7.9 months more as compared to the control arm, though it didn't reach the statistical significance, but that was not the primary endpoint of the study. If we analyze the subgroups in the overall survival, whether we can derive any conclusion, it was seen that those who had high volume disease, especially lung and liver metastasis patients, they benefited the most, even with OS benefit. So those who had lung or liver metastasis, the median overall survival was 37 months, and numerically it was 14 months more as compared to the control arm. You can see the wide separation of the curves. In the trial, again it was analyzed whether PIK3 mutation detected from the tissue or plasma made a difference. No, it didn't. So whatever method you do, the benefit remained the same. In the study, it was also found that the time to next chemotherapy was delayed by almost 9 months. So this was one more advantage of using PIK3 inhibitor. We can postpone the chemotherapy. The response rates in the study was very good. When we compare to the fulvestrant alone arm, when we add PIK3 inhibitor, the response rate almost doubled from 16% to 35%. And the responses were durable. The tumor shrinkage happened in almost 3 out of 4 patients who had measurable disease at baseline, which suggests that the depth of response and durability of response is very good. So alpelisib comes as 150 mg tablet, 200 mg tablet and 50 mg tablet. The dose is 300 mg daily. So you have to take with food once a day along with fulvestrant as per standard dose. If we come to the safety profile, there were some peculiar side effects in the study. So the common side effects, when we speak of any trial, we have to see how much was the grade 3-4 toxicity. Though in the study overall it was well tolerated, but if we talk in terms of grade 3-4 toxicity, especially hyperglycemia was very common. The next comes skin rash and the third is diarrhea, which is manageable. So why hyperglycemia occurs? Because it is a class effect. Whenever we inhibit the PIK3, the insulin also acts on the PIK3 receptor for the glucose input. So if you block the PIK3, automatically glucose won't go to the cell. So hyperglycemia occurs. So that's why diabetes is very common. And one more thing what we should understand in managing hyperglycemia whenever we are using PIK3 inhibitor is, we should not use insulin as much as possible. So if the hyperglycemia is grade 1 and 2, metformin is the treatment of choice. Whenever hyperglycemia is grade 3 and 4, that is fasting blood glucose is above 250, stop the alpelisib for few days, then you can give metformin, increase the dose, you can add insulin sensitizers, and insulin should be the last option as a rescue medicine. So dietary and lifestyle modification is also very important, because we know that when we give PIK3 inhibitor, hyperglycemia is very common. So in the study they modified. In the second phase of the study, they took only patients which had good control of sugar, that is HbA1c should be less than 6.5. Uncontrolled diabetes and type 1 diabetes patients were excluded from the study, and they found that diabetes can be easily managed with oral metformin. So whenever we start this drug, since hyperglycemia is very common, we monitor the fasting glucose weekly for at least 2 months, and HbA1c should be monitored every 3 monthly. The next common side effect noticed in the study was rash. There was no grade 4 toxicity of rash noted in the study. And again, in the study, it was seen that there was a learning curve. So when we use prophylactic antihistaminics and topical steroids, the incidence and severity of the rash significantly reduced. So in whom PIK3 should be tested? So PIK3 should be, mutations should be tested in an advanced breast cancer, which are hormone positive and HER2 negative. By which method? You can use either tissue or liquid biopsy. You can done by companion diagnostics or NGS, and it is available in India routinely. So whenever we do a biopsy, if it is a liquid biopsy and if it comes positive, you can start the treatment. If it is negative, then you can always go back to the tissue by reflex method. So to summarize, PIK3 mutation is present in 40% of hormone positive or HER2 negative advanced breast cancer, and it indicates a poor prognosis and endocrine therapy resistance. So we have a drug alpelisib which specifically targets PIK3 mutation. It nearly doubles the progression-free survival in the study. The PFS was 11 months as compared to 5.7 months in the control arm, with durable response rates, and safety information if you manage hyperglycemia and skin rash. Otherwise, it's a very safe medicine to give it. So based on this, the NCCN made it as a category 1 evidence to give alpelisib in hormone positive HER2 negative advanced breast cancer who progresses after first line endocrine therapy. So with this, I will conclude. Thank you.
Thank you, Dr. Ravi Tippeswamy, for telling us when and how we can use the PIK3 inhibitors and how to manage the toxicity. Now we move on to the panel discussion. I request Dr. Ravi Tippeswamy to stay back and be connected. So as we will be a part of the panel discussion from medical oncology side, as the other two panelists have not joined. I request Dr. Vishnu to proceed with the panel discussion. He can introduce the panelists and proceed. Thank you.
Good evening, everybody. Can you?
Yeah, we can hear you. We can see your slides.
Yeah. So the panel discussion for today was a discussion about breast cancer in a young lady. So I would like to welcome the panel members for today's panel discussion. Dr. Venkatachala, who is a consultant surgical oncologist at HCG Hospital. Dr. Mahesh, who is a consultant surgical oncologist at HCG Hospital. Dr. Vadiraja VM, who is a consultant radiation oncologist at Manipal Hospitals. Dr. Prakash Ramchandra, who is a consultant radiation oncologist at Sri Shankara. Dr. Divya, who is the consultant radiologist at Sri Shankara. Dr. Rekha V. Kumar, who is the professor and head of pathology at Shankara Hospital. And Dr. Annapurna, who is the consultant and chief of gynec oncology at Sri Shankara. From the medical oncologists, we have Dr. Ravi Tippeswamy and Dr. Sai Vivek joining us. And of course, Dr. Ravi Divakar will be around. So,
could you just full screen it by clicking on enable editing? It's enable editing. It's in front of you. Right corner. Top right corner. Enable editing.
There, yeah.
You can just slideshow it, sir. It will be full screen. Fine, sir. Fine.
Yeah. So the case for discussion for today is a 29-year-old lady who presented with a history of a painless lump in the right breast since 1 week. She also has a history of ovarian cancer in the family. Her mother expired due to ovarian cancer at the age of 61 years back. She has no siblings. Her cycles are regular and she is married since 1 year. On examination, she has a hard lump of 3 by 2 centimeter in the right central quadrant at 12 o'clock position, 1 centimeter away from the nipple areola complex with a restricted mobility. The skin and the nipple areola are normal. In the right axilla, there is a 1 by 1 centimeter lymph node which is firm in consistency and mobile. The neck is normal, the contralateral breast and axilla are normal. Systemic examination is normal. With these clinical details, I would open up the case for discussion for a further approach to the management. Dr. Venkatachala?
She's a young lady. I would, as you can see, that she has a positive family history. So I would like to go ahead with first the mammogram, sonomammogram, to see what exactly is the status in the breast as well as in the axilla, because one lymph node is what you're feeling. I would be thinking about more lymph nodes. And after that, I would like to go ahead with the throughput biopsy from the breast lump.
Yeah. Anybody else has any other?
She is a young lady.
Yeah, please go ahead.
Hello. Yeah, Dr. Mahesh here.
Yeah, please, Dr. Mahesh, go ahead.
Even though we know that in young patients suspecting breast cancer was rare before, but nowadays the incidence is increasing. So we should always consider them to be malignant also, or we have to rule it out. So here in this case, ultrasound is the first investigation, and based on that, if there is a suspicious mass, so here she has to go for a core biopsy. That's the first thing we have to do. And depending on the report, we have to plan further imaging and further treatment. Yeah.
Yeah. Dr. Annapurna, you wanted to say something?
Yeah, I just wanted to know what is her parity like.
She's nulliparous.
Okay, then we should always, we must remember that in our clinics every day, we see at least 1/3 of the women are younger women. Either they're not married or they had just one child. And we always should ask for this history of parity and offer them fertility options, which should be done at the first sitting itself, first consultation after doing your biopsies.
Yeah, that was very clearly addressed by all three members of the panel. So going ahead, we have to get a breast ultrasound with the mammogram. What are your opinions on the MR and MRI of the breast?
Once it is diagnosed as a malignant lesion, I prefer in younger patients, prefer to go for MRI because of chances of having dense breast, and we might miss some of the multicentric lesions. So we prefer to do MRI in younger patients, and especially if they have a dense breast.
Okay.
PET-CT would, once the diagnosis is over, would reserve the PET-CT to see how many axillary lymph nodes are metastatic.
So this was the mammogram which was done. Dr. Divya, you want to elaborate on this?
Yeah. As you can see, a young lady. So we have got a heterogeneously dense breast. Can you hear me?
Yeah, yes. We can hear you.
Heterogeneously dense breast. It's a right breast. And there is a indistinct margin, equal density, irregular, dense, equal density lesion in the upper central region of the right breast. And on the MLO view, you can see axillary lymph node, but it is difficult to comment whether the node is enlarged or not on the mammogram. And also you can see the biomarker or breast marker clip, which is placed at the lesion. There are no macro or micro calcification. There is no architectural distortion or asymmetries in the breast. So the next step at this moment, the BIRAT score will be 4C in this patient. So we would proceed automatically to the breast ultrasound. We don't have the breast image ultrasound here, but there was a indistinct, irregular hypoechoic lesion with mild posterior acoustic shadowing and vascularity in the upper half at 12 o'clock position. So basically this lesion that we were seeing on the ultrasound correlated with the mammogram finding. So the overall combined score of right breast will be BIRATS 5, because we have got more features on ultrasound as well as on mammogram, which are pointing towards malignancy. In this, although she's a 29-year-old lady, but features are pointing towards malignancy. So it's a BIRATS 5, 95% chance of being malignant. The next step would be to perform ultrasound guided biopsy of the right breast lump.
So the patient underwent a true cut biopsy of the right breast and the FNAC of the axillary lymph node. The true cut biopsy report was invasive carcinoma NST grade 3 with ER/PR and HER2/neu being positive. Dr. Rekha, you want to come in here?
Yeah, I think this was quite clearly an ER/PR positive. 4+2, 6 all-red score. Progesterone receptors 4+2, 6. HER2 is 3+ positive. And I think the Ki67 also to note, it is around 40%.
How many cores would you ideally expect on a core needle biopsy?
The more the better, I would say, really. But definitely at least 2 or 3 should be there, if not 5 or 6.
Okay. So, Dr. Venkatachala, with this information...
what was the grade of the tumor, Vishnu?
Grade 3.
Grade 3.
Grade 3, yeah.
NST, grade 3.
So, going by this information, definitely, as Dr. Mahesh pointed out, I would like to do a MRI of the breast because young patient, a family history is there. And we would like to do MRI of the breast to see if there are multicentric disease rather than a single lesion. And opposite breast also must be evaluated. I would not like to go with a PET CT because the axillary lymph node status is not much. Even the lymph node 4 millimeter cortical thickness may be metastatic, but rest of the axillary lymph nodes are not showing any uptake. But the MRI may show a better picture.
Yeah, absolutely. We don't have the MRI images, but they correlated with the mammogram.
Before that, Dr. Vishnu, I think because she has got a family history also, and we have to go for BRCA testing in this patient.
Yeah, I will come to that. I will come to that. So we're just finishing up the imaging. So anything else for you to look at the metastatic workup?
That lymph node is positive or negative, FNAC?
Negative.
Yeah.
So the FNAC was reactive. The guided FNAC came as reactive.
You can consider for a CT scan thorax and abdomen because of the ovary also probably should be looked into right now.
Yes, even though there are not strict guidelines, but everybody does do CT scan thorax and liver. We always want to image liver also. So it is routinely practiced in every center.
Why I also endorse Dr. Mahesh is that the chest X-ray may not pick up internal memory nodes. There may be negative axillary node, but we don't know about the internal memory node. So also the MRI, when it is done, the radiologist can also look into that area because we see that area will be seen on the MRI.
Okay. Agreed.
So CT scan thorax and abdomen, pelvis is a better thing rather than a PET CT scan.
I agree with Dr. Venkatachalam. We can comment on, we do comment on internal mammary lymph nodes when we do the breast MRI.
Okay, that's a good point. Dr. Ravi Divakar, Dr. Swami, any
I would definitely go for further imaging, a CT or PET CT, especially because she's a young lady, grade 3 tumor, Ki67 40% and HER2/neu positive. So risk of metastasis could be high. So I think imaging, depending on what is available, CT or a PET CT, would be definitely important. And Dr. Govindrajan pointed out in his talk that in almost 1/3 of the patients which they had done an analysis, they had upgraded the tumor stage.
Yeah.
So I think it is in order to do investigations further.
So in like Dr. Govindrajan pointed out, though NCCN is very conservative when it comes to early breast cancer in terms of systemic imaging, I think most of the centers in India do practice an aggressive imaging strategy for metastatic workup, especially in young women with higher risk factors. So this patient...
If the axillary lymph nodes were like 3-4 lymph nodes in the axilla, I would have probably suggested a PET CT.
Yeah. So this patient is non-metastatic. Her metastatic workup came out to be negative. So coming to the further discussion on genetic profiling of this patient, Dr. Mahesh, you were discussing.
This we have to do this test because she has got a family history and her age is 29 years. So we have to go for BRCA testing. And since it is easily available, I think every patient should be advised to go for gene test. Yeah.
Yeah. Would a BRCA testing change your management, Dr. Ravi Divakar? Dr. Ravi Tippeswamy?
Yeah, presently, no, in terms of cancer for this patient, but definitely we will like to counsel for the future. So how to follow up the patient and for the family members, it will help in future management.
Since we know that she will also be looking for fertility preservation right now, you can't think of removal of both the breasts or the ovaries.
Yes.
So she would be requiring the minimum possible, that is the breast conservation surgery as of now. But in the future, after she has 1 or 2 kids, whatever is her choice, that option can be considered.
Yes, I agree with Dr. Venkatachala. She is young and nulliparous right now. She has to plan her pregnancy and complete her family. And as we all know, even in BRCA positive women, the incidence of both the incidence of ovarian cancers occur or any fallopian tube cancers occur later. So even risk reduction surgery in a non-CA breast, non-CA patients, we offer at 35 to 40 if it is BRCA1 and 40 to 45 if it is BRCA2. So for this lady, I will want to wait. I will not interfere with her ovaries right now with respect to BSO as a risk reduction surgery.
Can I just come in?
Yeah.
Yeah, I think we should do a broader panel of germline mutation where it includes all hereditary breast ovarian cancer genes and not restrict to BRCA1 and 2. Because young lady, HER2 positive, she's not a triple negative disease, and there's a family history of ovarian cancer. Look at all genes, the A10 gene, the CHAD gene, the PALB gene, everything has to be looked at. I think it would be better to do an extended panel and not restrict to only BRCA1 and 2.
She'll be subjected to multi-gene testing.
Correct. You want to go in for a 21 gene test at this stage itself, or you want to?
No, they do a NSG sequencing.
Or you want to do the
common breast cancer, hereditary breast cancer genes mutations are tested.
One is you can do all the panels, all the tests. Is one option is available, that is by NGS. Other one is because 80% of these mutations are by BRCA1 and 2. You can do BRCA1 and 2 first. If it is positive, there is no need to do other tests. If it is negative, then you have to do other panels.
Yeah, that's very clear, Dr. Mahesh. So you can go for an NGS, or you can do the BRCA1 and BRCA2 and then going for the remaining genes. So how would, Dr. Annapurna, how do you plan her pregnancy since this patient might very well receive chemotherapy and hormonal therapy? What are the options of fertility preservation for her?
Presently, lots of options are available for fertility preservation. She is young, she is married, so you have the partner also. So you can preserve her oocytes. That's what is oocyte preservation, cryopreservation. We can do it, which gives a pregnancy rate of around 60% with them. Or embryo cryopreservation also we can do now that she is married. And that gives a 40 to 50% pregnancy rate post fertilization, post her IVF treatment. So these two options are there which can be suggested to her. We can always buy time. This looks gross, broadly, it looks like an early stage disease. So it will. We can buy time of 2 weeks. We can put her through the IVF treatment and retrieve the eggs, oocytes and mature oocytes, and then fertilize it and cryopreserve the embryos. And then put her back on for treatment for breast cancer.
Madam, oocytes or embryos?
Oocytes will be taken from the patient and then fertilized in the lab, and then embryos are preserved.
Okay, thank you.
If she wants, she can also go for some oocytes, if they are in excess, will be cryopreserved also.
If they are married, if the patient is married, it is better to go for embryo preservation. If she is not married, I think oocyte preservation or even ovarian tissue preservation is also a method or way of doing it.
Yes, sir. Ovarian tissue preservation, we do it when they're not married. Generally. Yeah. Now that, this lady looks married and nulliparous, so we can go for oocytes. It gives a better pregnancy result than tissue cryopreservation.
What technique you use, madam, in this? Because, for example, we cannot stimulate this patient because she is ERPR positive. So is there like a different technique, like in vitro?
They will generally they give it with letrozole. So when you give it with letrozole, the duration that is taken is generally 2 weeks, and the evidence whatever is present in right now is not shown that it is going to worsen the breast cancer treatment or outcome per se. There is no evidence to say that. So standard protocols of IVF treatment are followed, and eggs are retrieved, the oocytes are retrieved after stimulation and subjected to cryopreservation of embryos after fertilization.
So I just want to stress here that this is a very important point. If there are any postgraduates listening in and watching, that before you jump into treating the patient, these are all the things you have to make sure that it is done. You might overlook certain things like the pregnancy part or the oocyte retrieval, and these are the things which you must bear in mind when you're treating a young lady. So how do you want to sequence your treatment? I open it up for the panel. Dr. Mahesh, you want to go in for surgery, or you would? Is a triple positive?
Yeah.
P2 N0, possible N0 on FNAC negative.
So if this is actually if the patient is if we can upfront, if the patient is a candidate for conservative surgery and you are able to maintain a good cosmetic outcome, surgery would be my first choice because she is all three positive. If it had been ERPR negative and HER2 positive, then I would have gone for NACT for this patient.
Anybody beg to differ?
Yeah, irrespective of the ERPR status in HER2 positive patients, I think neoadjuvant therapy is the treatment of choice. If possible, chemotherapy plus Herceptin plus pertuzumab, trastuzumab plus pertuzumab would be the treatment of choice. I think you do the upfront chemotherapy with Herceptin and pertuzumab, and then assess at the end of 6 cycles, then proceed with the breast conserving surgery. Depending on the pathology report, you decide your further trastuzumab treatment or HER2 targeting treatment.
Yeah, going on the same line, would you do a sentinel node before starting this treatment, or would you be happy with the FNA report?
Sentinel node biopsy can be done before NACT or after NACT also, but initially we used to prefer doing before NACT, but now literature is showing it is better to do after NACT because one is you can avoid doing 2 surgeries. Second is you can even if there is a microscopic disease and it becomes negative, then you can still avoid axillary dissection. So it nowadays prefer to do post NACT.
Agree with that. So I agree with Dr. Ravi Divakar. So this patient received 6 cycles of TCH.
Only one thing, Vishnu, you are showing this image. There's only one clip placed.
Yeah.
I have always.
I totally agree with you, Dr. Venkatachala. I am also a strong believer of placing clips at the margins rather in the center.
Yeah, at least two or three clips.
So that's specifically why I have brought up this case as well. Like we've had discussions in the past, so that we know that there are clips being placed at the center as well. So yeah, Dr. Divya, would you like to comment on this? This is a post NACT image of the same patient.
Sure. So you can see the MLO image with clip, a pre-therapy image, where the indistinct margin, even though the tumor is indistinct, with the help of the density, you can readily say that after 6 cycles of chemotherapy, there has been a partial response to the treatment, only looking at the mammogram. But however, we proceed to do the ultrasound. Also, even on ultrasound, there was a 50% reduction in the overall size of the tumor. So by combining both, there was partial response to the NACT. And coming to the clips, the only one clip was placed. Usually we place 4 clips at the medial, lateral, and superior and inferior margins of the tumor. But because of financial constraints, because each clip costs like 4,500, and knowing that
Dr. Divya, I mean, we leave the financial part out. I mean, there are, Dr. Venkatachala is also very well versed with.
Mahesh and myself, we have started using Liga clips.
Yeah.
So 18 gauge needle or a Chiba needle, and our radiologist can also put it under ultrasound guidance. LT 200 clips are available for around 400.
Yeah.
400 rupees, 6 clips. So it is very cheaper option.
So we'll leave that financial part out. So basically, you're saying there's a partial response in this, which
partial response to chemotherapy.
Yeah. So this is after taking 6 cycles of TCH.
So was any MRI done again?
No, the post NACT MR correlates with the mammo. Okay. The patient was planned for breast conservation surgery. How would you like to address the axilla? Would you, I mean, after consent, of course, if the patient opted for a mastectomy, you would go for a mastectomy. Anybody would want to offer a mastectomy versus breast conservation surgery? Dr. Mahesh?
No, this choice, see, there is no consensus, there's no randomized trial to say that BCS is and mastectomy are equal in BRCA patient, positive patients. So here, generally, what they say is, BCS is also an option in BRCA positive, but they should understand there is a slight increase in the ipsilateral breast recurrence and also contralateral breast new cancer occurrence. That risk is high. That patient should understand. It's a choice of the patient. I would like to give both options. It's a choice the patient has to take.
I'm very happy that you brought out that subtle difference in BRCA positive patients with the ipsilateral breast recurrence. Dr. Venkatachala, would you also offer?
This lady was BRCA positive?
Yes.
Is she BRCA positive?
Yes, sir.
No, but I would still
Which
go
one?
for breast conservation, because once
One.
she's BRCA positive, doing one mastectomy now and other lactation and other issues, those things will be a problem for her immediately. We'll still consider for a breast conservation surgery as of now.
Okay. How would you all like to address the axilla?
Definitely a sentinel node biopsy of the axilla has to be done.
Agree. So I just want to put this scenario in front. So let us say if the patient turned who was a clinical node positive at presentation and then downstage to an N0 after neoadjuvant therapy, what would be your options here?
That clinical N0 must be this thing also on the imaging also, it should not be showing much.
Yes, this is considering imaging in the.
Yeah,
it depends on how many nodes were positive in the upfront.
It is just the solitary node which was positive.
Yeah, you can still consider for a this thing, a sentinel node biopsy.
Sentinel node can be, but you have to be very careful here because false negative rate may be high if you don't follow some basic principles. One is you should use a dual technique. Second is if you have placed a clip, it will help in recognizing that positive node also. Third is you should take multiple sections and if possible IHC is also done. And fourth is you should remove at least more than 3 nodes. 4 and above nodes should be removed in sentinel. If it is less, the false negative rate is more than 25%.
Yeah, so the higher retrieval of a sentinel node will decrease your false negative rate. So that is very aptly said. So would you have any experience of a targeted axillary dissection, either of you?
Yeah, we few patients we have done there, which has means we have put a clip in the lymph node, and after NACT, even that lymph node was also removed. Mainly that will reduce your false negative rate.
So coming back to this patient, she underwent a wide local excision with the sentinel node biopsy with a dual dye technique. The sentinel node was 1 on 3, and axillary clearance was completed. So the final report was 1 node out of 10 was positive. The residual tumor size was 2.5 by 2 by 2 centimeter with a grade 3 invasive carcinoma, the DCIS being present at 10%. And there was partial response to therapy. The evidence of response with a significant amount of tumor remaining. And the lymph nodal response was metastatic disease present with evidence of response to therapy. Dr. Rekha, do you want to comment on this? What would be your challenges in reporting a post-NACT specimen?
So 3 nodes were sent for frozen section, the sentinel nodes, out of which, so these are examined entirely. Anything which is more than 4 millimeter is bisected, and anything less than 4 millimeters is bisected. Anything larger is chopped up at each slice is 2 millimeters. So we make sure the entire, all the nodes and 2 millimeter slices of those nodes are examined at the time of frozen. So one of the 3 showed a macromet at the time of frozen, and that is how it was reported. And the size of the largest dimension of that was 4 millimeter, this positive node. And there was no extra capsular spread. This was at the time of frozen. So Vishnu, if there's anything you want to...
Yeah, what would be your challenge you have in reporting a post-chemo specimen as opposed to a fresh specimen?
Yeah, so this is basically, it depends on the amount of response. Now, in this case, there was an obvious tumor. It is 2.5 by 2 by 2 centimeter. So this is obviously visible. And this is not a challenge because we kind of address this the way we would a specimen which has not received neoadjuvant chemotherapy. So the challenge would be in those cases where there is complete response or near complete response, where you have to map the entire tumor bed, make sure you give enough bits. Even in this tumor, we have actually grossed the entire tumor. Anything less than 3 centimeters, the entire tumor is actually put into blocks so that we can examine it. But as I said, if the tumor bed happened in another case, if it's a large tumor bed, so that is a challenge in the sense that you have to make a grid and make sure you examine the entire bed. And that is in one cross section. And in case on the initial blocks, there is no tumor, you will go back and give rebits also, because you want to be very, very sure before you say it's a pathological complete response. So in that, it is a challenge. Similarly, finding nodes, not the ones sent for frozen, but in the axillary dissection, because post-chemotherapy, the nodes can become small, they're difficult to make out, they're softer. So, and the number of nodes that are retrieved are less. So it is more of a challenge to make sure that one has really retrieved all the lymph nodes that have been dissected.
Right. Thank you, ma'am. Thank you. Would any of you have done anything different? Dr. Mahesh, Dr. Venkat?
No. Whatever has been planned has been done. Don't think there would be anything different.
All right. So is Dr. Prashant Kesri, are you around?
Dr. Prashant, you have to unmute yourself.
Okay, Dr. Venkat, if you want to go in for an oncoplasty in a post-NACT setting, what would be your preparation?
What was the quadrant where the tumor was located?
It was the central quadrant, 12 o'clock.
Exactly retroareolar or?
12 o'clock, 1 to 2 centimeter away from the nipple area.
Okay. So if the nipple can be preserved, if we can take some ducts in that region, obviously we would like to do a frozen section of the margins at the time of surgery to be safer, so that we don't have to go back again to revise the margins. So definitely, we would preserve the nipple and the areola, as we know that how much of lactation and feeding is possible from that breast is difficult even after surgery and radiation. But since the tumor size is not much, we like to use local intraparenchymal breast flap, rotate it and fill into the defect, because as we know, the boost will be given to that area. We'd also place 1 or 2 clips in that area now for the radiation oncologist to localize or boosting. So I think she would definitely, if the tumor was not very close to the skin, we won't like to remove the skin. So only a parenchymal flap would be enough. Otherwise, would have to use those mobilize the nipple areolar complex if necessary, so that you get a better cosmesis by de-epithelializing the skin around the nipple and areola.
So going back to the medical oncologist now, how would you further sequence the adjuvant treatment for this patient?
Well, since the patient had residual disease post NACT, now we have the option of TDM1 to continue for another 1 year.
Would you like to give only this thing, or any further residual disease was more?
Yeah, there are options, sir, but the preferred option is to give an HER2 inhibitor for 1 year TDM1.
Okay.
If they are not affordable for that, then we can give 4 more cycles of anthracycline and then continue with the remaining trastuzumab. So both options based on the affordability. Ideally, we give dual HER2 inhibitor in any city setting, but most of the time, because of the cost constraints, we are unable to practice.
So, Dr. Ravi Thikaswamy, with dual HER2 blockade, they say the percentage of PAT CR is more. Could you just elaborate what the differences is with giving Herceptin alone and Herceptin and Perjeta together?
Yeah.
So it depends. No, the PAT CR, it depends on your ERPR receptors also. If ERPR positive, your PAT CR is around 35 to 40% only. If it is ERPR negative, your PAT CR is around 70 to 75%.
True. And between dual HER2 and single trastuzumab, again, the PAT CR rates increase by another 10%, 10 to 15%.
Yes. So how long would you, if you are going to give TDM1, how long would you want to give it?
Yeah, generally 1 year.
Do you want to give it in isolation, or you want to add?
No, since she is hormone positive also, later post radiation will continue with remaining TDM1 and hormone therapy.
So you wouldn't add hormonal therapy as of now?
Yeah, because she has to undergo radiation also.
Yeah. So what is your take on ovarian suppression for this patient?
Yeah, many of the time in an HER2 positive, generally ovarian suppression is debatable, but say if she is ERPR strongly positive and HER2 negative, then ovarian suppression would have more benefit.
Okay. One, coming back to the pathology, would any of you want to repeat the IHC?
Markers were positive already.
Initially, would you want to repeat it after? Dr. Rekha?
Yeah. Yes. Yeah, it is known that if a patient is treated with trastuzumab, a significant percentage, in some studies almost up to 1/3, they can become HER2 negative. So that the medical oncologist might want to know that.
But no, it's the difficulty is in whether you do it from the breast tissue and from the breast and axilla, both axillary node.
Normally, one would do it from the breast, from the residual tumor.
Only the HER2, not the ERPR.
If you repeat it, you would repeat all, right?
Yeah.
But usually the ER and PR may not change as much as the HER2.
Correct.
Okay.
I think as far as evidence is there is no evidence to repeat the ERPR HER2 on an operated specimen post neoadjuvant therapy.
Yes.
I think you continue your treatment. Your treatment is based on what you have diagnosed earlier and follow it up with that. I don't think if HER2 has become negative, you stop HER2 treatment now.
Right.
So thank you for that clarification, sir. So coming to the radiation oncologists, Dr. Prakash and Dr. Vadiraj, are you there?
Yeah.
Dr. Vadiraj, how would you want to go ahead with the adjuvant RD for this patient?
So the evidences are strong for conventional radiation, what Dr. Karthik mentioned, 50 grays, 25 fractions. But these days, we have moved to 40 grays or 42.5 in 15 or 16 fractions. Hypofractionation, that is acceptable. And whole breast and boost will be followed. Surgeons would have placed the clips, and we would, especially in young patients, boost is most important because recurrences are common without the boost. Supraclavicular fossa, I would definitely include as a regional irradiation because even after 6 TCH, still one node is positive and LVSI positive, HER2 positive patient. So regional irradiation is important. And APBI, definitely no. Hypofractionated regime, yes, I would still go with 40 grays in 15 fractions and boost, rather subjecting this patient to the recent fast forward because I'm still including the regional nodes.
Okay. Dr. Prakash Ramchandra, you want to come in here? So you have to unmute yourself. Dr. Prakash?
I don't think he's there.
Okay.
He's having a technical problem.
His video.
All right. So another question to the panel. So if this patient remained premenopausal after 5 years of tamoxifen, how long would you continue and what would be your strategy in further hormonal treatment for this patient?
Again, here we have to see how many years we are going to suppress the ovarian function and when she wants to conceive. Because we can't continue tamoxifen beyond 5 years, asking her to wait. So somewhere there should be a decision. Ideally, 5 years of hormonal therapy must be given before she conceives. But since she's 30, she can take 5 years of hormonal therapy. But if she wants to conceive after 2 years, as you know, that 80% chance of the disease coming back will be ruled out by that time. At that time, you have to stop everything. We have few patients, which myself and Dr. Shekhar Patil are managing. So we have to stop the treatment totally. Everything has to be stopped. That is a risk the patient has to take. Throughout the pregnancy and lactation, she has to stop that.
Yes, that is what she should be encouraged to get pregnant after 2 years of surveillance for cancer recurrence. If there hadn't been any recurrence, then she should be encouraged to go ahead with the fertility treatment.
Yeah, so what, as per the St. Gallen 2019, 18 months of hormonal treatment would be sufficient, then you can interrupt and then you can go in for a pregnancy.
Yeah, in this, I have a comment.
Yeah.
Yeah, she's a HER2 positive and she's received HER2 targeted treatment. So in these patients where HER2 positive, if you want to have pregnancy in between, there should be a treatment-free period post Herceptin for at least about 7 months before they can attempt pregnancy. That is the recommended thing. If it is only hormonal therapy, if they are only ERPR positive and she is on hormonal therapy with tamoxifen, then you can give a gap of 3 months and then she can attempt pregnancy. But in HER2 positive patients, at least a time gap of about 7 months is recommended before they can attempt pregnancy. And it is generally recommended that if you have stopped hormone therapy for the patient to become pregnant, try and get a family, you should not wait beyond 2 years after a break.
And
if she doesn't become pregnant within the 2 years, you have to go back to the hormone therapy and complete the hormone therapy.
So ideally, how long would you give the hormonal therapy?
Yeah, generally LHRH agonist is for 5 years. That is the basic minimum with tamoxifen. That is what is recommended. So I think if you are giving a break for pregnancy, you should complete that 5 years post-pregnancy.
All right. Would you want to continue tamoxifen for beyond 5 years?
Yeah, for most of my patients, once you stop LHRH, I continue with tamoxifen irrespective of what this thing is, up to 10 years.
Dr. Venkat, Dr. Mahesh, do you have any comments?
Yeah, up to 10 years is the tamoxifen treatment. If the patient was close to like 45 years or something, we could have removed BRCA1 positive, BRCA2 positive. We could have removed the ovaries and then considered for
This lady, since she has a family history of CA ovary also, you can, if she has completed her family by 35, you can counsel her to undergo BSO at between 35 and 40.
Would you also,
or at least 5 or 10 years earlier to that index case, whatever it was, 5 or 10 years earlier than that, or between 35 and 40, whichever is earlier.
how many of you would opt for a double mastectomy and bilateral oophorectomy for this patient upfront?
Upfront is not the thing what we practice, but definitely, as Madam said, once the family is completed, she can be counseled for the same with reconstruction.
That's right.
Skin sparing mastectomy.
Yes. So I'm just winding up here. Without just for completion's sake, Dr. Vadiraja, could you just elaborate on the indications for post-mastectomy radiation?
Yeah, since she is 29 years and after post-TCH, sentinel lymph node 1 is positive and completion out of 10, 1 lymph node positive, though there is no ECE. So this falls under the category of 1 to 3 lymph nodes. But since she is young, it is always better to treat, include the regional nodes and the chest wall, because the chance of recurrence are there.
Okay. So anybody has a different take on this?
Yeah, naturally, because it's a post-NACT node, one node positive because post-NACT. So we don't know, maybe it may be downstaged. So preferably better to go for, especially in younger patients, more risk of local regional recurrence also is high. So I think it's preferable to go for radiation also.
But there are few options of, it's a gray area, one lymph node positivity to consider for radiation. So we have to.
No, but she is young, 29 years, and
correct.
In front of NACT, she has one node.
Yeah, but that one node was there even before imaging also. The prior imaging also showed only one node. There was not many nodes. That is the only criteria which goes against consideration.
Okay, I think we're running short of
I
time.
have just one more comment.
Yeah.
Yeah, irrespective of the hormone status, receptor status, if this patient was young and we were giving neoadjuvant chemotherapy, there's a concept of using, if other ovarian oocyte preservation or cryopreservation is not an option, there is an option of using LHRH agonists upfront, right from the beginning, to suppress the ovarian function so that the fertility issues are not that, as long as you continue the chemotherapy, and then you can stop this thing if she is ERPR negative, irrespective of the hormone status.
So I'll just conclude the panel discussion with my last question. So since we are in the era of a pandemic, we can't avoid this question. So would the presence of COVID-19 change your management of this patient?
Initially, we were a bit skeptical. We waited for 2-3 weeks to know how the virus behaves and what preventive methods have to be used. Later on, we have adopted some modifications in our surgery, the PPE kits and masks. So the management is almost the same. Only thing is the patient should not be COVID positive when she goes for general anesthesia or before starting chemotherapy.
What about radiation, Dr. Vadiraja? Would you change anything?
We have already moved to 40 Grays 15 fractions hypofractionation followed by boost 10 Grays 5 fractions. So definitely she is not a candidate for fast forward trial because fast forward was only for node negative. So it won't change.
Yeah. So anybody else has any comments, or we'll close this discussion and go in for the question and answer session?
The only thing I would say was, if this was metastatic and an elderly patient, postmenopausal, you could have used hormone therapy with targeting of HER2/neu. You may not have used chemotherapy in a COVID scenario.
So I thank all the panel members again for sparing their valuable time and having this intellectual discussion. I thank the organizing committee for this opportunity. I thank you all. So we go on to the next session after this. Thank you.
Dr. Vishnu, I think you can continue because I don't have the questions in the chat box. There are a couple of questions.
Okay, I'll continue. Yeah. So So there is a question on false negative PET. Is a false negative PET related to any specific histology is the question. Dr. Govind Rajan, are you there?
Yeah, I'm there.
Yeah.
Yes, it is actually related to histology as well as grade of the tumor. Most importantly, FDG is not a cancer-specific marker. We have to understand that. We are taking the metabolism as a surrogate marker for cancer. So whenever there is, because of this, we are having quite a few false positives as well. So on the other hand, because some tumors are slow growing and low in their mitosis levels, as in the case of, for example, invasive lobular carcinomas are very slow growing tumors like tubular carcinomas, unlike IDCs. They are known to have false negative PET. And also those patients with very, very low KI, 67 levels, also are known to have false negative PET findings. But here the issue in that particular case that I showed, it was actually not just a PET, it is PET and CT. Generally, a big tumor is relatively better visualized on a contrast enhanced CT. So when the CT is also not picking up that lesion, probably that is because it's a diffusely infiltrating kind of a tumor. So both morphology as well as histology, both are important as far as PET CT negativity is concerned.
Thank you for that information, sir.
Yeah.
So there is a question on BRCA. Isn't BRCA mutation a relative contraindication for BCS? Dr. Mahesh, you want to take that?
As I told you, already we discussed actually, the ipsilateral breast recurrence is high, and also contralateral breast new tumor occurrence is also high. It's a choice. It's a patient's choice actually. See, what we prefer is especially those patients who are very much worried about recurrence and further treatment and have to go there. They generally prefer to go for mastectomies, and those who want better cosmetic outcome, more psychological. It's a patient choice. I leave it to the patient. But if they ask me the questions, I always say there is an increased risk of local recurrence. Ipsilateral breast recurrence is there.
Please unmute.
Hello.
Yeah, thank you. So there's a question on frozen section, Dr. Rekha. Would you want to elaborate on that? And there's a question saying which classification to follow for histologic assessment of post-NACT response.
Okay. What was the first question?
The first question is on frozen section. I think you have answered it in the chat box.
Oh yeah, I've done
just
that.
Elaborate on that.
Yeah, I think Dr. Karthik asked, is it important to embed the lymph nodes entirely, however big it is? Does it matter or just one section from a larger node is enough? So at the time of frozen, it's important, if there is a macro metastasis visible, just one bit from that one node is enough for that node. But otherwise, we must slice all the sentinel nodes at 2 millimeters, like I mentioned, freeze them and look for micromets, which will not be visible macroscopically. But once you have your paraffin block, so after frozen, all this material goes into paraffin blocks. So from those paraffin blocks, just one cut is enough, stained with hematoxylin and eosin. And for routine practice, there is no need to do step levels. There is no need to do IHC. So in routine practice, just one section is enough.
On a lighter note, I think Dr. Chaya has changed her receptor status to Karthik.
Oh, was that Chaya?
Actually, there is another question which is asked. Which classification to follow for histologic assessment of post-NACT response?
Yeah, there is no answer to this because there are so many classifications to follow. And some of them take into account the lymph nodes, some just look at cellularity, etc. But so we have Chevalier, we have Miller-Payne, RCB. Now, this residual cancer burden status is the one, index is the one that is actually from MD Anderson. And that would be the one to follow, because that is the one which is shown that according to the subgroups, that is hormone receptor group or HER2 positive or triple negative, the score that is given on using the software that is provided and using the data that we routinely report in our pathological reports, like the area of the tumor bed, the number of positive nodes, the dimension of the largest NACT in the node, the cellularity of the entire tumor, the percentage of DCIS. Now, all these factors are already there in our reports. We just need to give them a number and enter them in the software, and then we will get a score, which will put it as RCB 1, 2, or 3, and the other one is the complete response. So this is the only one in all the studies that are available, which has shown a very clear prognostic difference according to the subgroups of breast cancer. But there is otherwise everyone uses whatever is available, whatever they're comfortable with. And going by the AGCC 8th edition, which gives a YPTNM score, that is either complete response, partial response, or no response. So those are the ones that are commonly used.
Vishnu?
Yeah. Hello, sir.
Sorry, I just cut off for a while there. So
Yeah.
if there isn't any other question, I might want to make a couple of comments.
Sure,
if I may.
sure. You're free. You're free to.
Yeah, okay. So the number one is once the patients who have been given induction chemotherapy or the neoadjuvant chemotherapy, what do we do about the radiation? We may know that when you have the op surgery, you may have 1 node, 2 node, but it may be no node at all. But we don't know what was the nodal status before the neoadjuvant chemotherapy. So in these patients are already locally advanced. That's the reason they're going for neoadjuvant chemotherapy. So irrespective of the nodal status at the end of the surgery, we would recommend radiation for it. Hello?
Yeah.
I get the point. Yeah, that's number one. The other point I was going to make was about the adjuvant radiation. When should we do radiation? Now, we've talked about 3 nodes, 1 node, all those things. But the key thing is for everybody to understand that radiation has a 70% reduction in the risk of recurrence. And we know that every 4 recurrence reduced leads to 1% improvement in survival. Now, we need to assess what is the likely recurrence score or recurrence rate for every patient, and that would depend on the histology. Is the tumor size, whether it is ERPR, maybe whether the HER2 is obviously high, triple negative is much more likely to come back than ERPR. So therefore, if we have to look at what is the likely recurrence in that particular patient, it would vary from patient to patient based upon the histological characteristics. And then if there is a benefit from radiation, and radiation, mind you, is a relatively low risk treatment, the long-term toxicity aren't particularly significant. And when there is even a 2% benefit in terms of survival, that's worth giving. I mean, we do chemotherapy for even a 3-4% survival. So I feel that the radiation has a much bigger role than just looking to the number of the nodes, but it has to be looking at the overall risk of local recurrence.
Okay. Thank you, sir. Dr. Ravi Devakar, shall we conclude? Is there anything else?
I think we'll conclude.
Yeah.
Thanks to all the participants for having a very highly interactive session. I actually enter my 25th year of practice from tomorrow.
Congratulations,
and
sir.
When I started my practice, we were painting all breast cancer patients with one brush.
No.
Now today, we have learned so many new things. I think each patient of breast cancer is a challenge. Each patient has to be studied individually, planned, treatment has to be planned, investigations have to be done at an individual level, and treatment has to be done individually. I think that is the take-home message. There is no end to learning. Every day we learn more and more. Thank you for everybody for.
It must be personalized medicine, tailor making the treatment for the patient, not personal physician medicine. What physician wants.
And we should learn to treat the patient and not the disease.
Yeah. Thank you. Thank you, everybody.
Thank you.
Thank you for the. We had a couple of panelists who couldn't make it, Dr. Sandhya and Dr. Niti. We hope to have you next time.